on in a minute. I'm making sure this works, because if it doesn't, there'll be people who are really upset if they don't get in. And then I edit the YouTube afterwards, so anything we talk about will be gone. Okay. You should see me in a minute there. Thank. You see it live?
Well, maybe down, well, right down there. Maybe.
Huh. Maybe this is an old one. Oh, this looks like an old one. Why did it do that? Let me, oh no. Why is this not on live? Oh, maybe it is. Let's just see. To watching. Yeah, it is. You don't see it, honey, on the? Okay. Let's try again. Maybe this is it here. No. 14 views. That's it. Here you go. Right? That's it. I think. Oh no, that's not it. Okay, I'm just trying to see why this isn't working. 9 watching now. Started stream. Does anyone? Maybe something's wrong. Okay. It shows it's streaming, but I don't see anything.
I can see and hear you, just in case you wanted to know.
On YouTube or on Zoom?
I did the Zoom link.
Yeah, no. This is perfect. I'm also doing it on YouTube because there's too many people. They're not going to get on.
Understood.
I don't think.
Doesn't. There'll be people.
Oh, good. It is working. Okay, perfect. All right. I'm just.
Then I edit the YouTube afterwards.
Okay, so it's working, but you should be able to get on, Craig. If anybody, okay, so it's working on the YouTube, but I don't know. My husband's on the YouTube. He's not getting on. So let's see. If anyone wants to do me a big favor, that would be like really helpful. I'll tell you what to do. Okay. All right. So let me change the view for a minute. If anyone wants to do me a favor, who's good at this, I don't know why it's not working there, is go on YouTube, Margie Bissinger. I don't know why it's not working, Craig. My husband's computer's not working, but it shows me that I'm working.
Go back on or something?
Yeah, it should
You're
be.
live on YouTube. You're live on YouTube.
I am. Okay.
Yeah.
Okay, great. Okay, that's all I want to know.
I
Okay.
did the Zoom link.
Okay, yay. I'm live on the YouTube also. Okay, someone check that out. Okay, that's all I want to know. I don't know what my husband has it on. Let's try. I don't know why you can't get on. You can say hi to, this is my husband, Craig. You may have seen him on the podcast. He's not coming.
His head is chopped off.
His head is.
Well, that's
This is
sometimes.
him.
Get down lower so we can see him. Hi, husband.
Anyway.
You're a lucky man.
He's just here to do the YouTube. I mean, not really. He's just, I told him to answer questions on the YouTube, but if I hit live, I have no idea why that's not working.
I think we should turn me off and go back.
Turn you off and start again. All right. All right. But other people are telling me it's working on YouTube. So if it's working on YouTube, and I don't know why yours isn't working. Anyway, I'm just here to chat. Anybody want to, we can.
Yeah, I have a question.
Okay.
Can you recommend, I've been to 5 endocrinologists. They're terrible. They only want to test the TSH. And I don't feel well. I have weird symptoms. In Philly area?
Hold on.
No, I don't know offhand in Philly. I live in Morristown, but Penn is usually really good. But
she was the first one that I liked her a lot, but she said, I'm not going to.
You guys have to.
Your TSH.
I'm sorry, what happened?
She said she's only going to test the TSH. I liked her personality, but I mean, it's like a game.
A lot of people have their audio on. They need to shut their audio off.
Okay, and I have Melanie here who's going to make sure everyone's muted. So don't worry. Don't worry now about that one. Once it starts, we'll have everything set off. You know, I don't know offhand endocrinologists. You can write to me in support@margiebissinger.com and I can see if anybody knows anyone. Usually
maybe somebody you know. Okay.
No, that's strange though. Usually they do a more comprehensive test in terms of in terms of just that.
Some will do, but I would like to get off of this miserable drug, this levothyroxine. I've been on it for 20 some years. But I'm the one that's really having to initiate everything and drop down the the dosage, and I just got blood work back today. I went on leothyronine. It didn't touch me
Barbara, we can hear
deeply.
you.
Okay, so the key is this. The key is this. The key is maybe you want a functional medicine doctor who's going to do like all the tests in terms of, more balanced thyroid tests. And so you always can go to the Institute of Functional Medicine, and they have a practitioner site and see.
Yeah, I've been on that. I'm actually at my second functional medicine doctor, and I second appointment, and I like him a lot. He's an MD, and he's also board certified in family medicine, neurology, and psychiatry, which is really interesting. And he's a homeopath, which I really like.
This sounds good. So yeah, I would
At
test.
Jefferson.
Yeah, I think, Jefferson's a good place. So yeah, that sounds pretty good.
So
we're
we'll
just
see.
set- Yeah, well, good luck with that. You'll know if people are good or not.
Oh, yeah, immediately.
Okay, Craig, you can just
Yeah, I
do
guess
this.
All right. So
If
where's
everything's here. You have to just turn it on. Everybody's here. And
I
if
guess-
people write to you, you can just add it. All right, if you can't do it, just forget about it. Okay, okay, just forget it. You can just write in here.
Where am I gonna prove it?
Okay, forget it. Lindsay's gonna do it. Don't worry. Don't worry about it. Don't worry about it. Okay, forget about it. Okay, so much for having him help me with YouTube.
You should have known better.
Having to answer questions because he's a physician,
Getting my
but
husband.
we can't get it together. That's fine. Oh, if someone would do me a favor, the person who's on YouTube, if you just, you know what? I'll do this. I should post. Oh, that's okay. Melanie's going to post. Oh, Melanie, you're on. So Melanie's going to put where, and also it's so fun to see where everyone's from. So put in the chat where you're from. That's always fun. And if you're new, I'd love to know how many people are new and have never been on any of, because there are new people here that have never come to any of these classes. There are many of you I recognize, and it's always so fun to see all of you. But I
Hi,
just,
Margie.
It's fun for me to see you and Dr. Kim. I mean, it really is. There's
Yeah,
a
no,
wonderful
I
camaraderie.
I love community. Oh, and Marty's here from Australia. Marty, what time is it in Australia? Good to see you.
It's 9:52 a.m.
Oh, okay, that's not bad. Oh, that's
Well,
good.
it's in Sydney, not in Australia, because Australia has different time zones.
Oh, yeah. Oh, that's not so bad. Okay. I know sometimes there are people here and it's like 3 a.m, different places.
Yeah. Can I clarify something with you?
Yeah, sure.
I mean, I know you've talked about this heaps of times, and I've listened to you and other people, even Keith McCormick and everyone. It's about exercise, about flexion of the spine.
Yeah.
I've started seeing a chiropractor, not for because I've got osteoarthritis in the hips, and I'm trying to postpone, I guess, my
Right.
hip replacement in the right hip, because I've done it in the left, but I'm trying to postpone in the right. So he's giving me some exercises, okay, to do. And the other day he
And
asked
have
me,
YouTube and the Zoom audio at the same time.
Okay,
Sorry?
great. So Melanie's going to put
Oh.
like links in the in the chat just about the 2 programs. So if someone could put those in YouTube, who knows how to work YouTube, since that would be fantastic at some point. Thank you. So continue, Marty. This is not part of the Q&A, Marty.
That's all right. So he asked me if I do sit-ups and crunches, and I said I don't do sit-ups.
No.
I said I had already told him that I had
Right.
osteoporosis, and then he said, and I've had this discussion with my trainer too, where he says that a little bit of flexion is important for the health of the spine. And I said, well, that's not what I hear when I've got osteoporosis. He said, you need a little bit of flexion for the spine, for the health.
No.
As long as you're doing other exercises, I guess. But so I don't know. It's
Yeah, the
hard to
truth
know.
is, no, the truth is that it's not going to cause a fracture, a little bit of flexion. You're going to get a little bit of that in your day anyway. But
Yeah,
no,
I
the
do.
truth is, I actually have my little spine here. If we
Yeah.
see the spine, we see what happens with osteoporosis is instead of when there's fractures and things, instead of being square shaped, move away. It's not the same time. Okay, just get away. I'm sorry. I don't need the noise. Okay. Get away. Didn't work. You're out of here. No, I'm teasing. Anyway, so you see how it's square, it's
Yeah.
wedge
Which,
shape. So when you bend forward, all the force goes on the area that's the weakest. So absolutely not. That is not good advice. There was a study a long time ago at Mayo Clinic showing people look, we're going to get flexion in our day, but we don't need to add additional flexion. It's not important. And you're getting motion and you're doing things. So, we don't, again, you're going to get some, it's not, but there's no reason to add it in. There's enough in your normal day that's going to have a little bit of flexion. They changed Canada the guidelines used to be no flexion, no rotation, but that's not realistic. It's just cumulative. You don't want to do much of it because
Yeah.
studies showed
sure.
fracture risk. Even a yoga study showed that people had fractures from doing the flexion poses. So
Mainly if you do a lot, I guess, more than
so
usual.
you just stick to your guns, Marty. You got
Oh
this.
my gosh, I've had the discussion with my
That's
trainer, and now, I mean, he's not.
Just say you're going to do things where you're bending, you're doing hip hinges with maintaining
Yeah.
your curves. You got
Because
this.
I'm quite tight. I'm not very flexible even in my back, so he reckons a little bit will help me. So I don't
No,
know. Have this argument
say
all the
I'm
time.
sorry. I'm sticking to my osteoporosis. You can do things where you're lengthening and moving and different things like that and qigong and all that stuff where you're getting good
Yeah.
motion in the vertebrae and that will loosen you up. So there's plenty of loosening things without doing actual flexion.
All right. Thank you.
Good to see everybody. This is so wonderful. Let's see.
Margie, it's just Melanie. I think it's a good idea that if people are on the Zoom that they don't have YouTube on as well, because they're going to get feedback from that.
Yeah,
So if
that's
they
a good
ask a
point.
question, so one or the other. If you're in the Zoom room, it's perfect. You'll be able to
Yeah, we
see
don't need
everything
to
that's
be on
going
both.
on.
I just had
Yeah, you
asked
don't need to be
someone.
on both.
Yeah, you're going to be on both, and it's not at the same time. My husband was supposed to monitor the YouTube and and it's not the same. It's not the same. It's off a little bit. So so yeah, that's a good idea. Don't be on both. If you're on the Zoom, there's absolutely no reason to be on YouTube. The only reason that we did the YouTube, and we don't even have 1,000 people on yet. So there's the only reason I did the YouTube was because um 2,697 people opted in for this. So I was
Oh
like,
my gosh.
yeah, can you imagine? I was like, oh gosh, I only have, but a lot of people do this and they get the replay. A lot of people can't come, but they know they'll get the replay. So I usually assume at least half won't come. But I want to have it available if there's overflow and people come late that they can go to the YouTube. That's the only reason I do the YouTube, just as a backup. But we're almost ready to start. We'll get Dr. I know Dr. Millman's here. We'll get her here in a minute and we'll get started. But I always love chatting. So good to see. Melanie, read out where everybody's from in the what people have written, where they're from. I'd love to hear.
Oh, goodness. Okay, I'll have to go back a little bit because there's a lot of
Just
questions
stop. Yeah,
already.
before we get like
Um,
a minute.
Finger Lakes, New York.
Nice.
Let's go down here. Lots of questions already, so.
Where's Paula?
Okay, well, I don't, we really want the questions raising hands. So raise your hand. Don't put it in chat. If we get stuck, we'll do chat, but we're going to go in order on the hand. So raise your hand to ask the question. If you can't and don't know how to, then write in chat and we'll help you with that. But the best way she's going to go through is if you really can't, you could write it in chat, but we're going to go through the questions in order. So just raise your hand. And if you go to reactions, I think that's what it is. It'll say raise hand.
Yeah, it's React, Margie. It's a little heart on the bottom of the screen.
Perfect. And then we get to see you in order, which is so good. And we're going to start in 1 minute. Dun, dun, dun. And it is on you. Excuse me. It is on YouTube, just so you know. But I'm going to but it seems like we don't have nearly the 1,000, so that's okay. And it went over 100. That's happened once. No, I can't let anyone else record this. That happened. I did that once before and it's messed up my recording. So I see some people, I'm declining anyone who asked that because the last time I did that, it completely messed up my recording. And I don't want to do that at all.
Margie,
Okay.
is my hand still up? 'Cause I don't even see it.
Who,
Barbara?
Who is it?
Barbara Kolodny Glenn.
Um,
Remember I
no,
put it
it's
up when you
not.
first
Barbara
got-
KG? Does that say
Yeah.
Barbara KG? No, do it again.
It
But we-
disappeared. Remember I put it up as soon as you got on.
All right, so you know what? I will tell Dr. Millman to call you first, then. You're right, you came on the first person.
Yeah, and I don't even see the option now, and I'm under
I can
more.
do it for you. I
And
think-
Margie, this is Jen. My hand went away too, and I was one of the
Oh,
first.
okay, okay, so we'll do Barbara, because I know you two were here with me before even quarter two. Okay, not a problem. We'll do Barbara and Jen. So what I'll do,
Thank
I'll
you.
call you and yeah, and then I'll and make sure you're showing your video so I can see you. Okay. Okay, so what I'm gonna do.
Thank you.
Sure. Okay, so I'm gonna pin myself and find Dr. Millman. Where are you? Let's see.
here.
Let me see your video so I can pin you to. There you are. Hello.
I'm here. I'm here. I've been here for a while.
Yeah.
I've been answering some questions in the chat.
Oh, you've been
Yeah.
working already.
And now I've realized that I have to have a power cord. So my husband's going to have to come in and get me a power
Know
cord.
that you're co-host? Yes, right? It shows.
Am I?
No, you're co-host. Okay, so I'm gonna pin you. Pin
And
me.
I saw that Jen and Barbara were both
Yeah.
they raised their hands right away and that
You were
at
early bird.
2:30. I was here at 2:30.
Okay. Okay, so here's what we're gonna do. We're gonna say hi, and then for those people who've never been on one of my classes, we have a little routine we do. But you know what? I have not hit record. Can you believe such a thing? Okay. Welcome everybody to the live Q&A with our very special guest, Dr. Kim Millman, who's here with me, and I'm so excited because she's always there's nobody, Dr. Millman, who's as good as you are at really answering like every question. I can answer a lot of questions, but you always bring such a depth of knowledge. And for those who don't know Dr. Millman has been a physician for quite a while, but she's done integrative osteoporosis for over 15 years and had such an incredible practice, very effective with amazing protocols. And we met quite a while ago, and I had said to Dr. Millman, everybody wanted to see her after the summit. Can I see you? I need a doctor like you. There just aren't doctors like you. And so then I sort of convinced her to start a class, which we'll talk about afterwards. And so she does have a class, Restore and Rebuild 100 Days to Healthier Bones, which has just been amazing. And I see there's some people who've come to the class. I teach part of it as well. And so she's done that. And then Dr. Millman asked me to start a practitioner program, which we did as well. And so, but she's just such a wealth of knowledge and really does this amazing integrative approach. And that's what I love so much about you, because it's all evidence-based and so effective. And oh gosh, she's helped so many people. So I'm so glad you're here to answer questions for everybody in my community and more. There are new people here too. And anyway, so welcome.
Thank you. Thank you.
Well, before
Yeah,
we start,
and we've even gotten like new testimonials from students who have been in R&R. We call it R&R just to shorten it. We've gotten a new testimonial from someone in R&R who's been in R&R, I think maybe 3-4 times. It just had a DEXA improvement. She's never been a patient of mine. She's just following. Hi, Kim. Following the advice that Margie and I have been giving for years, and
yeah, it's just so exciting because both Dr. Millman and I, you get a diagnosis of osteoporosis, and it can be a blessing in disguise because it's sort of a wake-up call, and it's the catalyst to take this action, to take action. And when you take this action, everything gets better. You figure out your root causes, your gut gets better, your joints get better, you get stronger. And people look back and say, that was such a great thing. So that's our attitude. And that's what we see. We see empowered people, mostly women, but men too. We see people empowered to take action. And it's just, and that's why we love what we do, I think, because it's people like you who want to learn, want to know what to do. So on that note, before we get started, which we will in a minute, 2 things. One, I have a way I start classes. So I'm just going to put everyone who's showing their video on. And then what we're going to do is I'll do it. I'm going to put all your videos on. Let's change the view for a minute. Okay, yeah, this is the most fun because you see the community here. And there's two ways to view this, just so you know. You know, on the top there's a view, you can see gallery, that's everybody. But I suggest you don't do that. I suggest for the class you put speaker, so then you'll just see Dr. Millman and anybody asking a question. Anyway, but what I want you to do is put an intention out there that you're going to get something from this class, whether it's your question or somebody else, that's really going to have a positive influence on your life. So put the intention out there, first of all. And then what we're going to do on the count of three, I just like everybody to get the good energy flowing. And this juices up. I'm not doing that much this one, but this is going to really juice up Dr. Millman. And so on the count of three, we'll just say hi, good energy. So you can unmute and then we'll mute again. On the count of three, ready? 1, 2, 3. Hi.
Hi, good
Hi,
energy.
good energy.
Energy.
Good energy.
Yay, good energy.
Oh my God.
There's Marita. Hi, Marita.
Okay, so now we're going to mute. And if people aren't muted, Melanie's are mute. Melanie's here. She's a big helper. And Melanie's going to also monitor the chat too. So if there's anything. So the way it's going to work today, I'm going to just, let me change the view for a minute. Okay. So the way it's going to work today is that Dr. Millman is going to raise your hand. That's the way we found it the easiest. If you absolutely can't, write it in chat. Melanie's going to monitor. But raise your hand and then Dr. Millman will go in line and hopefully we'll get to helping as many people as we possibly can. And we're gonna, we're willing to stay a while. Should I tell them our absolute max? No, I'm not gonna tell them our absolute max. I guess I could, but no, we have an absolute, we've learned we can only do so much before it's too much. So hopefully we'll be able to answer everything. And that's perfect. So I'm
We're not leaving before 5.
Yeah, we'll be here. We'll be here 2 hours. That's what we found. We found that 2 hours is a long time, but we get, lots of questions answered. And what I'm going to do, I'm just going to share my screen. I just wanted to show 2 quick slides, and then I'm going to turn it over to Dr. Millman. Okay, now it's interesting. I put the slides up, but they're not up now. Okay. That was very interesting. Just like I guess people's hands went down. That was very strange. Hang on one second. I just wanted to put up 2 quick things. Okay, here we go. And let me just do this. Oh, whoops, let's do this. Okay, can you see this, everybody?
Yes,
Okay,
we can see it.
Yes.
I think it's important, just a disclaimer, that the information in this program should not be construed as medical advice, even though Dr. Millman is a doctor, but we don't know your individual situation. So it's not intended to replace consultation with your physician or healthcare provider. So just know that. And there's 2 things we're not going to really go through right now, but in case you leave, I just wanted you to know about them. And and you can see the QR code here. The one is Dr. Millman's program, Restore and Rebuild, 100 Days to Healthier Bones. We'll talk about it more later, but I just wanted to give you the link, and Melanie's going to put it in the chat as well. But there's also the QR code that you can just put on your phone as well. Anyway, that's starting, just so you know, that's starting March 7th, and the actual first class is March 12th. And she always gives my community $100 off with happy S26100, and it's much cheaper until more. And she extended that for us. Initially, it was already over. But anyway, if you want to learn more and what she does and more things like this, she has these kind of Q&As on a regular basis. That's her program. And the second thing I just wanted to show you is that if you're a practitioner, we have this incredible program that Dr. Millman asked me if I wanted to do it with her, that we've been training practitioners. And so, because there's so many people who want one-on-one help, and there just aren't practitioners that really understand this integrative approach. So we've been training practitioners. We have 18, actually more, in our first cohort. I think we have 20, who are amazing. It's so incredible. I can't say enough good things about the people who've been in the program. So we have our second cohort starting in May. So if you are a practitioner or you know someone who might be interested, share the link with them. Anyway, I am now going to turn this over. I'm going to turn this over to you, Dr. Millman, and I'm going to get out of here. And why don't you explain before we get started, there's a certain way that Dr. Millman legally can answer questions. So why don't you just share that before I get off, how that is?
Yeah, so The thing that we don't want you to do is to give a lot of medical information. There could be a couple of labs, but like if first of all, you want to be as general as possible. So if you could say something like, you know, in a person who has a CTX of a P1NP of what would blah blah, what would you think about blah blah? You start going into more than CTX and P1NP and an L spine T score of this and of this. And I went to see my rheumatologist on such a day over on Winchester Boulevard and blah, 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 blah. You are absolutely asking for medical advice. And I will have to tell you that you're asking for medical advice. So you just keep it very short and keep it to one particular topic.
And do you want them to say if a person instead of them? Or that's
Well, yeah. If a person had this particular situation going on, or if this was a patient of yours, then what would you do? Or even a more specific question than that.
okay. So I'm gonna get out of here and I'm gonna just let you go, Dr. Millman.
All
And if you have
right.
a question for me, I'll be happy to chime
Okay. I
in.
think we're gonna start with Jen.
Yeah, there were two people first, Jen and Barbara. So yeah.
Oh, the other thing too, Melanie, I don't know if you can do this for us, but we want to do a 5 minute time limit. I know there is some way to there's I don't know if Melanie knows how to do that, but
Melanie, could you time us in? That's a great idea.
yeah.
Just 5 minutes?
Yeah,
Yeah,
five
5
five
so we
minutes.
get as
Yeah.
many questions as possible. We learned that on some classes Dr. Millman and I have been on professional classes. They have a timer, and that seems to really work.
Okay,
Okay.
will do.
Okay, thank you. So
Thank you.
just tell someone if they're,
All
if
right. So Jen, we're going to start with you.
Thank you. Hi. So, how do you know how much osteoarthritis artifacts in the spine and the hip, for example, affect the DEXA scan T score? And wouldn't the osteoarthritis skew the T score and make it appear more favorable than it really is?
Yeah,
For
that's
example,
mhm.
if a person had a negative 1.6 lumbar T score, but lots of osteoarthritis that was confirmed through the DEXA scan as well as spinal x-rays, what could be the actual T score?
Yeah, so the way to practically do this is you look at the individual T scores of L1, L2, L3, and L4. If you find that you look at the best, and let's just say that the best is -1 and the worst is -2.2, then the best at -1, because it's over a standard deviation, better than the worst, is likely due to osteoarthritis, and you throw that away. And you keep doing that until all of your vertebrae T scores are within a standard deviation. And if you have a really, really good report, which I don't see at all from, I see it very rarely, that actually will give you L1 and L2 T score, L1, L1, L3, and L4 T score. L2, they'll give you all the combinations and the T score if you get a really good report. And then you figure out which ones you have left, and then you get your T score from that report. That's the way to do it.
Okay, thank you. That's sounds labor intensive, but I'm willing to do it. Thank you.
It's okay. Let's see. How can I help you? Okay, so let's just do one really super simple. Okay, so best score at L1 is -1. L2, -2.25. L3, -2.5. L4, -2.5. You're going to throw out the -1 because it's the best one, and it's -1.5 standard deviations from -1 to -2.5 difference is negative 1.5 standard deviations. L1 gets thrown out. L2, L3, and L4 are all negative 2.5. T-score is negative 2.5.
Okay, that really simplifies it. Thank you.
You're
Thanks
welcome.
so much.
You're welcome. All right, Barbara. Hi, Barbara.
Hi. So nice to see you. And
So
I
nice
know
to
how
see you.
present the question that I think a lot of people will want to know the answer.
So, Barbara, it's so nice to see your ceiling.
Oh, really?
Uh-huh.
I thought
Or
you could see
something. I
me.
don't know what we're looking at, but
Oh,
we're
we just
definitely
see
not looking
gray,
at your
right.
face.
Seriously? So
Yeah.
I don't, it's right in front of me, my iPad.
Oh, okay.
I don't,
Well, it's fine.
oh, wait a minute. There I see. So does that help? It
No,
looks really foggy, right? It looks like it's muddled and I have no idea
yeah.
why. All
It-
right. Well,
yeah,
sorry.
that's fine.
Okay. So I always want to call it osteobean. Osteoben peaks at 2 years. If
Yeah.
ours hasn't improved, when do we stop taking it 2 years? And I have a little more to ask after that about this.
Okay, so that's a hard question to answer, right? Because the studies are showing that the BMD improvement is better at 2 years than at 1 year, and 1 year is better than at 6 months. So we know there's an improvement at 2 years. But if there's no improvement, that doesn't mean that the osteoben's not working. It
Oh,
could mean that there's something else going on that is negating the effects of the osteoben because we have a complicated body, right?
yeah, mine's really complicated right now.
So I don't think that I think the osteoben supplement is nice because of, so one of the things that helps the genistein work better is zinc. So it has 15, I think it's, no, it's 7 milligrams of zinc. And there you go. There you
I
go.
don't know why I
Whatever you
did that.
did,
Okay.
fixed it. Okay, and then it's got the CalMag in the dimalate forms, which is great. And
Right.
it's got a tiny bit of vitamin D. It's like 1,000 IUs of vitamin D, so you can take that off of whatever you're taking. And it's got a tiny amount of K. It's not enough of K. Um, so it's not, and then it's got the genistein thrown in. So it's not all that more expensive than say CalMag 2 to 1 is. So I don't see a big like expense to stop the osteo.
Okay. And I'm not looking at the expense. I'm looking at if it's safe or is it worthwhile or is it just more stuff I'm putting in my liver.
I get it. I do. I get it. But I would say that it's not it's such a weak phytoestrogen that it's not it's very safe. Very, very safe.
Okay. All right. So
Um,
the next
mhm.
you have, okay. I'm trying to make sure I get in my 5 minutes. If we have improved, how much is considered an improvement? And then the last question was, how long do we continue taking it? So first one is, if we have improved, what is an improvement? 5
Okay,
points,
well,
10
you
points?
you not only can see an improvement in the DEXA BMD, but you could also see an improvement in the CTX because remember that genistein is working as an anti-resorptive, just like Fosamax is, but also that is working like a sclerostin inhibitor, like Evenity does. So
So how many numbers, how many points is an improvement for your CTX?
CTX, in the study, the CTX was 150.
Went
That
went down 150
it
points?
went down by 150
Wow.
on average. And then the sclerostin values, I don't remember, and you're not doing your sclerostin values anyway, because that's research-based numbers. But remember, sclerostin Evenity, that's an anabolic, so could be helping to build. And I don't remember the BMD improvement, but it was as much as Fosamax. I think it was something like 3%.
God, I read an article saying 5 prunes a day is as much as Fosmex. And it wasn't a little silly article. It went on and on and on.
Well, that's because it's really high in boron.
Right. But that's interesting. 5 prunes. The article was about what's the best food for osteoporosis. And it went on very, very, very detailed. So, boy, I'd much rather eat 5 prunes than take a drug any day.
Of course.
So
Of
the last one, how long do we continue the osteoben if we're having success?
Forever.
Forever. Okay. Since it peaks at 2 years, you just keep taking it. Okay.
If you want to lose the effect,
Yeah, well,
it's not going to be a long-lasting effect if you stop it.
okay. And how long stopping it? Like if you take a breather on your supplements, sometimes you just can't take another one, so you take a couple days off here and there. Is that okay?
Oh, of course it's okay.
Okay. Okay. All right.
It's even,
Thank you so much.
I have patients who will take a trip and they'll go to Europe and they'll go, there's no way I'm taking my supplements with me. And I go, well, go have fun in Europe.
Okay, because I'm like that. Good. I'm glad that's safe. I've
Yeah.
never taken them with me.
Yeah, they might go to Japan for 6 weeks and I'll say, go have fun in Japan. Your bones aren't going to fall apart in 6 weeks.
That's
Thank you very
fine.
much.
Yeah. Yeah.
Okay.
Good to see you.
It was wonderful to see you, and thank you very much.
You're welcome. Karen? Hi there.
There.
Hey.
Hi. Is it, wait, not
No,
me.
no.
Is it me?
Karen
it's-
Lewis from
it's Karen
Vancouver.
Lewis. Yeah, that's right. Hi, Dr. Millman. I'm so
Hi,
happy
Karen.
to ask you a question. I've got some of these info things of yours regarding oxalates.
Okay.
And my question is, so I know it's really important to know how much calcium you're taking and absorbing.
Yes.
But I'm also really interested in the fact that I can pair oxalate-rich foods with dairy or some form of
Yeah.
calcium to mitigate the effects of the oxalates because I'm prone to kidney stones.
And remember lemon juice too. Lemon juice
yes.
is really important because it stops the
Yes.
supersaturation of the oxalate crystals, especially in the kidney.
Right. Oh, okay.
Mm-hmm.
So my question is, does that dairy that I'm using to mitigate the effects of oxalates count as my daily amount of calcium or not?
Probably not, but I think it's impossible to know how much calcium is going to be binding to the oxalates. I actually am nerdy just like you and thought about the same question myself. Is it a 1-to-1? Is it, every milligram of calcium is binding to every milligram of oxalate? What have I got going on here? What kind of relationship is it? I couldn't find the data. So, I would have to say that I'm kind of thinking that if you take around 100 milligrams of calcium with your meal, and you've got a high oxalate meal or at least a moderate oxalate meal. I don't know how much you're binding. Really, I don't, Karen, but probably 50 to 100, 50 to 75 milligrams maybe of that you're binding. And then the other thing that I don't think that I really, I did discuss it a little bit, but Trudy Scott just made this comment on her blog that nobody is talking about this. And I know that I talked about it, but I want to say a little bit about this, which is that when you have a gallbladder problem, you're not making enough bile. You don't even have a gallbladder. You don't have a gallbladder. You're not making enough bile, even though you have you have a gallbladder. Bile salts and bile acids are binding up fats, right? And they help the fats to absorb into the cells in the gut. And so the fats are no longer just, out there in the lumen of the gut. Now, if you don't have enough bile salts to bring in the bile acids, to bring in the to bring in the fats will stay out there in the gut lumen, and the fats will congregate around the calcium, and the calcium will be unable to bind to the oxalates. So it is really important, and some people feel a lot better when they have symptoms of oxalate toxicity when they take ox bile. So they can take ox bile as a supplement, and there are also nutrients that can help bile flow. I actually will probably add a little bit of this to R&R because it sounds like you're in R&R and you're starting with you're not?
No,
Oh, okay. Well,
not yet, but
okay.
I hope
Okay,
to
well,
someday. But
probably.
number six is what you're talking about here on this
Yeah,
thing that
see,
you
I
put
do talk
together.
about it, huh?
Yes,
Trudy
yeah,
says nobody talks about it.
yeah.
But that's really important to, potentially take ox bile too for oxalates.
Okay.
It can help a lot. And that could take, I feel like that could be as good as taking calcium.
Okay, wonderful. Thank you so much.
And the other thing too is if you don't have enough ox bile or lipase to absorb your fats, remember vitamin K and vitamin D are fat soluble vitamins, so you may not be absorbing those vitamins, which is not good for your bones.
Ah, right. Well, in Canada, you can only buy vitamin K in 120 mcg amounts,
Wow.
which is really frustrating.
Hmm.
So
Maybe
I mean, I'd
maybe
have to take
Marty,
50 of them or something a
are you
day.
sure about that?
I am
I'm
absolutely sure. Yes.
absolutely
I've, t-
sure.
I've asked my naturopath, I've asked people at, special pharmacies that,
Hmm.
yeah.
Because I know we had a Canadian student and we were helping her get some um, supplements and we were using iHerb.
Yeah, there's a lot of Canadians in my community as well. If anyone's here from Canada and you know about this, or you get it from a different way, just write it in the chat if anybody has information on that.
Well, and that must be MK7 then, right?
No,
It's K1?
um, what is it? I thought it was K2.
Yeah, it's K2, but MK7 is in micrograms.
Okay. Yeah, I'd have to look.
Well,
I don't
100
remember.
micrograms would be a decent amount of MK7, but um, I'm recommending all three
Yeah.
because of extensive research that I did on both the prevention of fractures with especially MK4 and then the potentially reversal or prevention of vascular calcifications. And the studies were done on K1 and K7. So now I recommend all three.
Mhm.
Thank you, Karen, for those questions. And Denise, you're next.
Hi.
Hi, how are you?
Nice to see you again. Yes.
Good to see you again.
All right. So this is gut. If someone had done a wheat zoomer and lectin zoomer like about 2.5 years ago, maybe a little more,
Yeah.
and the wheat score was greater than 6.
Uh-oh.
Soy score was 5.4 with an IgA of 5.0 and an IgG of greater than 6. Now, I know in your course at one point, I remember you saying, well, some people can go back to gluten.
Yeah.
Some can't.
I did say that.
And sometimes eating all gluten-free, it can get very sad for me.
Yeah, I
But
understand that.
I'm a little doing better since, I don't know, about a month now. But anyways, I was curious, how would you approach the idea of going back to gluten? How would you approach that? And how would you monitor that to know that this is okay or this is really yucky?
Yeah, I would Oh boy. I mean, that's really a hard one. Because of the
And
fact,
can you go back? Someone told me a while ago, oh, if you've been off gluten for a while, you can never go back. And that really scared me because I'm like, I
yeah,
always thought there might be some hope, maybe.
I don't think that's true that you can't go back, but there's two ways to monitor whether you're reacting again. I mean, one way is obviously that if there are any symptoms that come with the reintroduction, then you have to pay attention to that. And then, but the real way to know would be to repeat the wheat zoomer. And after about, I would say, 8 weeks of reintroduction. But really, in order to know, and this is going to get pricey, really to know, it would be doing the wheat zoomer. And if you really need to know for the rest of your life, and with such a high score to begin with, you may be in this category. You do the wheat zoomer before you reintroduce, and then at about 12 weeks, like at about 3 months, then you redo the wheat zoomer and see if there's a change. And you can also do that with CTX. But I find that so many people do so much better off of gluten, and it and if if someone were to see a CTX change after taking gluten out of their diet, and their bones are actually improving, and that's part of the strategy that a person was using, I would be very disinclined to bring it back.
Well, this particular person is on an anabolic, so I don't know about that, but
Then it gets very dicey to really figure it out.
and then the question becomes this whole idea of soy, which at one point, apparently I didn't understand it completely at first, but it's like I remember saying to you, oh, I don't eat much soy, and my number is what I told you. But then as I learned more, it's like soy lectin, soy this, soy that is in like literally everything out there in the world.
So I will ask
Um,
the doctor a question.
let's see. Am I there still or what?
Melanie, can you mute Marilou?
So the question then, I didn't realize that all these things had soy in them at first. I just thought when you said soy, it was like, because I don't eat soy, I don't do tofu. I thought I was golden. And then that, when you start looking at every label of almost everything that's in a package, or even things that are gluten-free, there's like soy something in there. And it's like, so you're gluten-free, and now if you got to get rid of soy, I'm like, okay, this is it's getting really difficult sometimes.
I know.
Soy's
in a lot of stuff, that's for sure.
When you travel or go out to eat, it's really, I don't know. Anyways,
so I think that my opinion about soy is a little bit different than wheat. That I think that wheat is a much bigger
problem area.
Yeah, problem to the bones. And to the body altogether, and that's one of the reasons, is because of its effect on zonulin, whether you're sensitive to it or not, because zonulin is a regulator of the tight junctions in the gut, and it causes leaky gut when it binds to its receptors. And wheat, when you eat it, will cause an increase in zonulin, and it doesn't matter whether you're sensitive to it or not. Soy, I don't believe that soy has that effect. So that's why I say kind of like gluten and wheat, like 12 months. Soy, maybe 9 months, bringing it back. And I wouldn't be as concerned about bringing soy back.
Okay, that's 5.
Okay. Yep, that was pretty good. Thank you.
You're welcome. Melanie, maybe we should mute everybody again. And then I'll I'll unmute myself and Margie can too. Okay. All right, Robin, you are next and you'll have to unmute yourself.
Hello.
Hello.
I'll be new to your class, by the way.
That's awesome. Look
Yeah.
forward to having you.
Yeah, thank you. So, what kind of success rate have you seen using HRT to treat your patients with severe osteoporosis? And what is your protocol for monitoring hormone levels and bone turnover markers to ensure the therapy is optimized?
Okay, so those are really nice general questions, but maybe a little too involved for today. So I'll do my best. So
Okay.
one of my patients had now first of all, HRT, when it's optimized and the target levels they're at the target levels, can drop a CTX by half. So I see this almost universally. I see CTXs of 700 dropping down to 350 after 6 months of HRT. So I see that all the time. I have a patient who she's 4 years in now into HRT, starting with me, and she is up by 13.5% on her lumbar spine. She went from a negative 3.7 to a negative 2.8 in her lumbar spine. I see the lumbar spine BMDs getting better with HRT and the hips stabilizing. Now, I do actually believe that the hips are getting better, but they're not showing on the DEXA scan. And there's some research studies where I can say that's probably true. Like in the vitamin K studies, there's like this volumetric CT scan that they can do to show whether the bone mineral density is improving. And they do this in research studies, and we don't do it, right, in practice. But there's many studies that show volumetric CTs getting better at the hips, like with vitamin K. It gets better at the hips, but we don't show it in the BMD. Onero, the Liftmore study, Belinda Beck said that they saw improvements in the hip on volumetric CT, but she didn't see it in the DEXA. And so so I think that that's actually going on in HRT, but I'm not perfectly sure of it. And as far as monitor, now I can't say that everybody's at 13.5% at 4 years, but I can say that many of my patients show those kinds of 3 to 7% improvements every year in the spine, and that the hips stabilize. But yeah, I'm not seeing the hips actually, the BMD improving on the DEXAs with HRT. Monitoring, I do a lot of monitoring. So I'm doing blood monitoring, and so if somebody is on a dose of HRT that I just started, until they get to their target, I'm monitoring them every 3 months. I'm monitoring sensitive estradiol, sensitive testosterone, and DHEAS until they get to their target. Once they're at their target, then I'll back off to maybe once every 6 months for a couple of times. And then I'm anywhere between every 6 months and every 12 months monitoring serum levels. I always do a dried urine Dutch estrogen metabolite markers once a year to make sure those are going in the right direction. And I'm having people keep up with their yearly mammograms. I'm having them do transvaginal, transabdominal ultrasounds to look at the endometrial thickness to make sure that I get it at baseline, and I'm making sure that is not going up and substantially. And so there's a lot of monitoring that I do, and that most traditional gynecologists don't do as much monitoring as I do. Some naturopaths will. And then my targets are a little bit different than I would say, because of the fact that I've done so much research in the bone sphere and know what it takes to get to improve the BMD. And then I'm taking into account some of the safety data where there's something called the timing hypothesis. And the timing hypothesis is that women who are greater than 10 years after they start after their final menstrual period, if they start hormones after 10 years or they're older than 60, that they have an increase in progression of cardiovascular disease if they start hormones. But what they found was that did happen, but it was dependent on the estradiol level. So the one of the lowest levels where that started to really take off was 30, 35, 40. So I keep my older women in that 20 to 35 range, and I'm always looking at cardiovascular markers. So.
Okay, perfect. And how long can you be on HRT? I would think you'd have to do it for a long time if it's this, because osteoporosis, right?
Indefinitely.
Okay, and that's safe, I guess they're finding that's safe to be on it for that long?
I mean, the big Medicare study that was just done was in Medicare women. They were all older than 65. And so I have a woman who's 82 on hormones. I have so many women in their 70s on hormones. And
Length of
and
time?
and if you think about it, in the end game, so if somebody goes on HRT and they have an improvement in their BMD and then they go off HRT, what's just happened? They just went back into menopause.
Okay.
Can you, Dr. Millman, can you call on Kimberly Johnson? She had her hand up and then a while ago and she has to go in a little bit.
Sure. Sure. Okay, Robin, see you soon.
Okay, thank you.
You're welcome. All right, Kimberly Johnson.
Unmute Kimberly. Okay, there you go.
Okay, good. Thank you.
You're welcome. Hi.
Hi, Dr. Millman.
Hi.
I worked with you back in 2024.
I
And
recognize you. Hi.
yeah, hi, it's wonderful to see you.
You too.
So, what would you do with a person who, over about 2 years, went from a CTX score of 831 to 465 and a P1NP that went from about 89 to 78? And yet, with a recent, in the last couple of weeks, DEXA score, the spine actually got a little bit worse. And the hips, the femur was shifting, some were a little bit more and some were a little bit less.
Yeah.
And so I'm confused about that. And what might that person do in that case?
Yeah. So, first of all, that is a great improvement in the CTX. So you said 700s down into like 450?
831 to 465.
Yeah, so that's almost half. So that's great. Now 465 is not optimal. It's still breaking down too fast. Because if you remember, the optimal range is 250 to 350. So 460 is still 100 points over. So that's not showing total bone stability. But it is showing a huge improvement. So I would have expected that if that person's CTX stayed at 860, that their DEXA would have been much worse than it was. And it also depends on how long that those bone turnover markers have been in the more stable range. So if that's just a couple of months at 460, you wouldn't expect a DEXA to improve. And it, but if that was 460 over 2-year period, then you would expect that DEXA to be slightly worse. Does that shed
So you'd expect
light?
you'd expect, yes, thank you. So you'd expect it to be slightly worse, whereas if the CTX hadn't come down, it could have been a lot worse, the DEXA. So
If,
the fact that
if the CTX was at 800, there probably would have been about a 7% decrement. And if there was only a 3% decrement, then that is what you would see if it's, because remember that there's a 3%, it's called the, what is it? The least change error, something like that, where just by taking a DEX at another time point in time, there could be a 3% error. So there's 3% error in DEXs, period. So even if it's like should be the same, if it's within 3%, it's the same. Right? So
okay, because
yeah. But 7%, that's significantly worse. And so if it were, if it were 800 for 2 years, so you not only have to look at the bone turnover markers, but you need to look at the rate of change of the bone turnover markers, and you need to look at how long the bone turnover markers have either been stable or unstable.
Okay.
So it gets a little bit tricky to do this. And I can only say that, after 15 years that I'm just kind of have a sense of it.
And would that person then be able to continue to decline medication and until, seeing how it would go? Or
so this would be valuable for everybody. So my red flags. So first of all, Margie and I coined this term, short-term medication bridge. So what does that mean? Medication is done for a short term. It bridges natural to natural. And you should be doing natural all the way through, attacking all the root causes, because if you don't, you won't be stable when you come off medications, and you won't be able to get off of medications, and it won't be short term. So my red flags for needing a short-term medication bridge is a T-score of negative 3.5 or worse, a CTX of 8 to 900 or worse, and or fractures. So anybody who has either the three, I say they should highly consider some kind of medication. So would I ever recommend a bisphosphonate by itself? Only in a couple of situations where and it would probably only be IV reclass, which is like, okay, somebody has breast cancer, and actually this person put in the chat, this is one of my situations. They have breast cancer and they're on anastrozole, and anastrozole destroys your estrogen, and they can't do anything about it. They have to be on anastrozole. Well, maybe a year of IV reclass brings their CTX down from, I've seen CTXs on anastrozole in the 1200 range, and I've had my patients go on IV reclass and they come down to 200. At least they're safe for a while for them to finish the anastrozole, and then they can think about like doing an anabolic, or they could do an anabolic. So when I talk about medication, I'm talking about either very short-term IV reclass because of extreme situations, or anabolics.
And that's
five, sorry.
Okay. Thank you.
You're welcome.
Thanks a lot. Yeah.
Okay, Francesca.
Hi, thank you.
Hi.
I'm very glad to be here. It's the first time I've been on one of these, and I will be doing the class, so I'm excited about that.
Awesome.
Yeah, me too.
Look forward to seeing you.
Yes, me too. Thank you. What would you do if you saw a DEXA from, a difference in the L1 to 4 from 2.6 to minus 2.6 to minus 3 over 2.5 years, but a dual femur from minus 2.9 to minus 2.5 over the past 2 years, and the endocrinologist saying you must take bone medication. You will just change the brands in order to avoid bone tumors.
Okay, so just so lumbar spine went from what to what?
Minus 2.6 to minus 3 in
Now,
two
do
and
you
a half years.
know minus 2.6 to minus 3? Do you know what a percent change that is? It sounds like about four or five.
It says minus 6%.
Minus 6%, so that's significant.
Mhm.
So, okay, and the hips.
This one particular dual femur, neck left, minus 2.9 coming back up to minus 2.6.
Okay, so the lumbar spine got worse and
I'm
the
sorry,
hips got
2.5.
better.
Yeah. So
Hips got
getting
better.
better by 7.6%.
I've seen that. So one of the reasons could be, and Margie could probably talk to this better than I could, but exercise that actually loads the hips better than the spine could maybe do that. Is that true, Margie?
Yes, a lot of times people do all sorts of hip things. They're jumping, they're doing a lot of leg things, and they're not doing the spine. That's one of the, you really need to work on the spine extensors and muscles that attach to the spine. So we do see that. Are you doing an exercise program?
Oh, now I'm doing Robbie Stahl's fitness doctor program.
I'm not sure exactly what that contains, but if it contains more things for the femur, yes, you could see that where you've improved, and then you just really need to do more. Yes, so that could certainly be one
Yeah,
of
and
them.
I think that metabolically, I don't really see the spine improving and then a hip getting worse. I don't see that. I mean, it probably has happened here and there, but and then as far as you must go on medication, I, you know, so so I had a patient. I think maybe it was Wednesday. And Yeah, it was yesterday. Yeah, so the patient, she wasn't at negative 3.5. She was at negative, I think she was at negative right around the numbers that you just gave me. I'm not going to say they were yours, but they were around the same numbers, like negative 2.9, negative 3.0, something like that. And I
Sorry,
recommend
what?
those.
Oh, yeah. Cool.
Okay, Jeanette, mute yourself. Oh, okay. So they were around the 3.0 numbers, and I told her that I thought she should go on medication. Now, why? Okay, number one, she doesn't want to go on HRT, which is totally okay with me. She's already on a restricted diet. So she's already taken dairy and gluten. She's already done the food stuff. Does she have a little bit of dysbiosis that we're working on? Yes. Is she already weightlifting? She's already been weightlifting for 2 years. I don't have a lot of stuff that I can really do with her. So that's another thing to kind of look at, because from my point of view, there are five big needle movers: medications, HRT, protein, if somebody doesn't have enough protein, exercise, and what is the last one?
Parathyroid? No.
Parathyroid. That's right. Parathyroid. That's right. Those are the huge needle movers. She didn't have a parathyroid problem. She was eating enough protein. She was already exercising. She didn't want to do BHRT. And and God, now what is my last one? So anyway, so I don't have a lot of things that I can do. Now, all this other stuff that I think is really important, sleep and stress and you know, some of these things can actually be needle movers too, but they have to be pretty extreme. Most of the time they just stabilize and they're not like huge needle movers by, you know, improving everything. So for her, I was like, yeah, I think medications. So it's a very complicated decision to make. But I think in a lot of cases, I feel like the endocrinologists just don't have enough tools in their toolbox to think about things in a different light. And they're very quick to just, you know, state that a person needs to be on medication for the rest of their life.
Yeah, because this person is on levothyroxine for 10 years already, 12 years, and the side effect is osteoporosis. So there's that concern as well. And the Robbie Stahl, I'm not
So, you
sure
know,
if
I
it's
don't know about that with the levothyroxine being a risk factor because I think it could be a risk factor just if people are over medicated because that doesn't just make sense to me that if your thyroid, maybe it is because
Hashimoto.
well, Hashimoto's is another thing, right? Because that's the autoimmune inflammatory part of it. But just being on levothyroxine, you're not the first person who's told me this. But if I think about even, let's say that the studies say this, if somebody's appropriately medicated, that shouldn't be a reason.
That was time, Dr. Millman.
Thank you.
Melanie, I think we're going to need to go to 3 minutes.
Okay.
We're going to need to speed things up so we can, because I can get a whole lot of questions answered in 3 minutes. Okay, Karen. Thank you, Francesca.
Which one?
Oh, I don't know.
Okay,
Somebody who doesn't have their video on.
that's
There,
me.
that's
Hi.
you.
Hi, thank you.
Mhm.
So, quick question. If a CTX and a P1NP are in normal ranges,
Mhm.
but one still wants to learn the underlying reasons for osteoporosis,
Mhm.
what are the next tests to take? I know in your last webinar, you spoke about the 24-hour urine calcium test for renal leak.
Mhm.
Is there an order that would be best as to which test to take?
Well, what I would say would be because you know, I have a somewhere between a half an hour and a 45-minute webinar on this. We have a podcast on it. It probably would be good for you to listen to the whole podcast. But you absolutely have to know the parathyroid stuff. You need to know.
Okay.
So, but there's
I
a
listen.
whole,
Yeah,
there's a
I
whole
actually
list.
listened to that and I made a list, and the parathyroid is okay. What I haven't received the results from the 24 for the renal leak for the 24-hour urine
Mhm.
test yet.
Mhm.
Calcium and vitamin D are good. So you know the CBC I know is important. Well, that came out fine.
That's
Um,
MCD.
so I just was thinking maybe it's the GI map. I don't know.
Yeah, I mean there's lots of places to go, right?
Yeah.
You know,
Hmm.
there's sleep, there's stress, there's blood sugar, there's inflammation, you know, there's dysbiosis, there's gut healing, there's systemic inflammation, there is gut inflammation, there is food sensitivities, so there's lots and lots of places to go.
Right. Okay. So then again, I guess I would have to go down the list and check off each test to see if anything comes up in each one of those, either one of
Yeah,
those.
that's what we do in my program.
Okay. And then sideline. So I'm just going to out myself here. You also mentioned if you already have had a fracture, then you should be on medication.
No, I
So,
didn't say that. I
no?
didn't say that. I just said that it was a red flag and that
Okay.
those people those people should look at their whole entire situation and potentially consider a medication. So if somebody has the triad of w- a T-score worse than negative 3.5 or worse, a
Right,
CTX of 800 or 900,
right.
and a fracture, well, that person really, should really go on meds. Now, a person who had, and then what kind of fracture was it? I have a patient who just told me about, she fell on the cement backwards from her bike, and she got a spinal compression fracture. Somebody who doesn't have osteoporosis might have that kind of fracture. So is it a
That's
fragility
3 minutes,
fracture?
Dr. Millman.
Okay. Okay.
Understood. Right. So it's still a work in progress over here. I understand.
Yeah.
Thank you very much.
It takes a while to figure all
Right.
this.
So should we all give ourselves like a year, 6, 8 months? We have to just keep moving forward.
I think I think a year is a very reasonable time. Yeah.
Okay. Thank you so much.
You're welcome. Hi, Marita. How are you?
I'm so happy to see you again.
So happy to
I
see
just have
you.
to say, big heart, lots of knowledge, lots of compassion. Thank you for doing what you do. So
Thank you.
I think after I was working with you, oh, okay, let's go to somebody I know. So,
Yeah. Not too many details.
yeah, has been taking Prolia
Okay.
for 2 years.
Okay.
And doesn't really
Don't
want to.
tell me 2 years, please.
That's what her GP told her, and
I know.
um,
No one
she
should be.
doesn't want to do that anymore.
Yeah. So Prolia has a very nasty rebound. And the rebound gets much worse the longer a person is on it. And the optimal duration is 1.5 years on Prolia. Now, 2 years isn't too much longer than that, but it is a really good idea for a person who's been on Prolia for 2 years to transition off onto the only thing you can do is IV reclast. And if I were to tell a person who I think lives in Washington,
Yes, you're right.
is that true? Yes.
You are right. Thank you.
I would tell them to get on Dr. McCormick's appointment book as soon as possible and have him help.
Is that Keith? Okay. I will tell her.
Okay.
Thank you so much.
You're welcome. Cynthia.
I'm trying to unmute myself. Dr. Millman, thank you very much. I think I got the drift with respect to the questions I was going to ask, but I'll just pose them anyway.
All right.
What do you consider a severe T-score in an individual?
Negative 3.5.
And with no other risk factors, can one improve their DEXA through lifestyle changes? If they have a 3.5, slightly worse in some cases, slightly better in other cases.
So the Lift More study shows that Belinda Beck did with the Onero is that you can absolutely increase your bone mineral density with Onero exercising. You can absolutely increase your bone mineral density with HRT. Can you increase your BMD enough with HRT and Onero? Well, I have plenty of people who do that, but when they're at a negative 3.5, I'm kind of saying to them, really, don't you want to just have like a little boost for a while, like get a couple year boost in there, and then we'll be in great shape. You'll be out of the woods, and then the Onero and HRT can take over, and you'll be good to go until you probably won't have to go on another med again. You know, it depends on how young a person is. And it also depends on how active that person is too. If they're super active, that's another reason to want to go on meds earlier than later.
Thank you.
Does that help?
Yes, it does.
Okay. All right. That's why I was saying those are the needle movers: HRT, exercise, protein. If there's a parathyroid problem, and meds. Those are the needle movers. And Evenity is the best needle mover we have. Judy. And I'm not afraid of Evenity, and I recommend it a lot to my patients.
Hi, hopefully this is the Judy that you're
Hi,
asking.
Judy. Yes,
Hi.
you're next. Yes.
I'm actually going to ask the question about why cancer people shouldn't take the class.
Yeah.
And so if your cancer is hormone negative and your doctor said you could be on HRT, would that be a go for the class?
So is that the case that a doctor said that a hormone negative breast cancer patient could be on HRT?
Yeah, my primary care doctor was actually going to prescribe it, who herself had breast cancer, and she said to ask my oncologist, and my oncologist was okay with that, given that my cancer was hormone negative.
Wow.
And there's a lot of people who, I mean, I don't know if you're familiar with Sharon Stills. She's a naturopath in, I believe, Arizona. She also, this is another part of my question is, she believes the 24-hour urine is best for testing metabolites versus dried urine. Wondering what you think about that. And I'm throwing,
Oh,
should I
wait,
not throw?
wait.
Sorry.
Okay. As far as hormone metabolites?
As far as, determining before things are prescribed, yes, to determine your levels, she recommends a 24-hour urine test.
For hormone metabolites.
Yes, it's my understanding.
So
Before
you're talking
prescribing.
about like the 2-hydroxyestrone, 4-hydroxyestrone, 16-hydroxyestrones.
I don't know what specifically was mentioned, but before she prescribes, that's her recommendation versus dried urine.
Well, so yes, that is probably true. 24-hour urine tests are a pain in the butt, right? A lot of people don't want. I don't do them because I feel like, so first of all, I use Dutch, and they're dried urine, and when they have validated studies to show that their dried urine is very comparable to serum levels in the way they portray them within their dial system. So because their dried urine has been validated, I use Dutch. And the dried urine that is taken over multiple points in the day is one of the best approximations of a 24-hour urine test. That's why I use them. Now, I'm not going to argue with an integrative oncologist. I'm not going to argue with a naturopathic oncologist where that's all they do all day long is look at oncology. I'm not arguing with any of them. That's not my wheelhouse. Just for you to know. Triple negative breast cancer's not my wheelhouse. Oncology's not my wheelhouse. My wheelhouse, because of the fact that I know that that herbs can be estrogenic, and quite frankly, most people are not as savvy as you are. They're going to come. I'm telling people you cannot come into this class if you have if you've got a female hormone related cancer, because I can't go through every herb combination that I have. It would take me months and months and months to say this one's a little bit estrogenic, this one's not. Like I just can't do that. And I don't think that it is responsible of me to have a really complicated patient in the group. And not only I want them to be safe, and it's not that I don't trust people in the group to be their own advocates, but I don't want to be responsible for something that happens because they misunderstand or something like that. That would be terrible for me. And it's not a CYA thing. It is a CYA thing, and it is important for my license, but it's more my integrity. And it's more my ethic and it's more my compassion that I don't let people in. And I don't want somebody really complicated to be confusing the whole group.
That's time.
Thank you.
So if you would like to email me further, I could let you sign a waiver if you wanted to come in.
Okay, thank you very much.
Okay. Marty, I think you look like 10 years younger. What did you do?
Do I?
Yeah, you look fantastic.
Oh, okay. I don't know. I'm doing
Yeah,
trying
you can.
lots of training, that's for sure.
Yeah, you can ask Denise and like Denise and Barbara, they'll tell you too. Wow.
Oh,
Yeah,
all
I
right.
think she looks great too. I noticed
Doesn't
that
she
too,
look
Marty.
great?
Yes, yes,
Oh,
you
thank
really do
you.
look.
Yeah.
I don't
Marty's
know,
in
do
both
lots
of our
of things. I watch what I eat, I exercise, I
You
take
look really, you
supplements. I don't
really
know.
like got lost like, I don't know, 5 years at least. You look great. Yeah.
Oh, right. Okay. Well, maybe because I did my hair yesterday, and when I do my hair, I always look about 10 years younger.
I think actually your hair looks thicker.
Maybe. Yeah. A little bit. It's still fine hair, but anyhow. But yeah, can't complain. Well, nice to see you again, Dr. Millman, and Margie
You
too.
too. You too.
I've got a few quick questions, I guess. So with the estradiol,
Yeah.
do you keep raising the level until the CTX is within the acceptable range, the 250 to 350 or not?
No.
So what happens if you raise the estradiol up to 35, which is what you said there,
Right.
for people my age, I guess,
Right.
and the CTX is still too high?
My personal my personal philosophy is that 20 to 35, that's the safety range for older women, and
Okay.
I don't violate it. I mean,
All right.
I think there are some times in which the levels are going to vacillate up and down anyway. There may be a point at which there might be points at which maybe somebody's at a 20 and maybe somebody's at a 43, right? I'm not worried about a transient 43, but I don't want it to be consistently 50.
High. Okay.
So and maybe that's a situation where you add a little genistein or a little bit more estriol, right?
The weak one, right?
The weak
Estradiol is the
one.
weak
The
one.
weak
Yeah, yeah.
one, yeah, that's not
Okay.
going to raise the estradiol levels.
Right. Okay. Another quick question. How long can you keep taking stinging nettle for? This person takes it to lower the SHBG.
Right.
She was taking it and it lowered it. It wasn't low enough, but it came down a bit, then stopped taking stinging nettle and went up again. So now this person has been taking stinging nettle for quite a while again, haven't checked it.
I mean, really, I really don't know that it. So when people ask me that kind of question, I think about whether there's any dependency on that particular thing, and I don't think there's the dependency occurs with nettle. I mean,
What do you mean?
I have people who do like nettle tea like every night for
Right.
decades. So
So when you say dependency, what do you mean exactly? Like whether there's any?
well, yeah, dependency would be like if you stop it, your body really needs it, and
So it's okay to keep taking it, you think?
I think so.
Okay. All right. One other question. Have you heard of the ALCAT test, which is a
Yes.
food
Yes.
sensitivity? How does
Yeah.
that compare with the food zoomers? Because I forgot who it was that was talking about it, and they said it measures responses to foods and other substances at the cellular level. Measures food immune reactions through
I
stimulation.
can't give you an educated answer about that because it's been at least 10 years since I looked at the ALCAT, and one of the reasons why I decided against it was something around $1,000 at the time.
Well, I'm not sure how much it is. I can't remember whether I looked it up or not, or whether it's available in Australia or not. Actually, I'm not sure. But
Yeah.
if you remember, Food Zoomers was about $1,000 to do. That's why I never did it.
Oh, wow. And the food zoomers have changed too.
So
So
I
now
don't
the
know.
food zoomers are like there's only a 7 food bundle and it's 600, and that's my clinic price. So
Right.
yeah, so it's a little more expensive if you
Yeah,
get
that's why I never did it, because it was so expensive. So
That's 3
anyway,
minutes.
people are liking MRT. Isn't that right, Margie? Is MRT that some of our students are like, I think it's MRT. That looks interesting, and I don't think it's that expensive. Look that up.
Yeah,
okay.
the students from Restorative Health, I think, are using that.
MRT, right, Margie?
Yeah, I think that's what it's called.
Yeah.
Okay.
Okay, Dr. Millman, are you finished, Marty? The next person who says her hand keeps going down, let me just find where she.
Oh, okay. It's not Pam next.
No, for some reason she said her hand was up and it kept going down. Michelle Cleaver, can you call on her?
Yeah, we can
Thank
call Michelle, sure.
Are you there, Michelle?
Hi. Yeah, I'm here. So this person does urine, morning urine pH testing, and it's always below the 5.5 limit of the test strip. And she's added electrolytes and does 200 milligrams of potassium, and that gets it up to about 6 most days. Are there other things that you would recommend trying? And is that morning urine testing a good way to do it, or do you recommend switching to a blood test?
Okay, so the morning urine is going to tell you whether there's a potential metabolic acidosis that could be causing too much leaching of the calcium from the bones and then getting rid of it in the urine. So my standard recommendation is 500 milligrams of potassium. I think you might have said 200 milligrams of potassium. That wouldn't be enough for me to actually see that change. Or it might change a little, but not enough. So that might be a potential. Also, magnesium helps that. Magnesium in probably a little higher doses than most people take. So those would be the two things. Now, we're talking about the urine pH versus what other testing modality? What did you say? That's how I do it, is the first morning urine pH.
With the 500 milligrams of potassium, is there a particular way to take it, all at once or throughout the day or a certain time of day?
Yeah. So the one that I recommend is Seeking Health, and it's called Optimal Electrolyte. And it's just a scoopful of it in water. It's got 500 milligrams in it of potassium. It's got a bunch of magnesium in it. One of the reasons why I like that particular one is when you look at electrolytes, you need to be careful of the sodium. Some people are sodium sensitive and they have high blood pressure, and like there's this one electrolyte combination that's very popular. Actually, it's called LMNT, and it's got a ton of sodium in it. And the optimal electrolytes from Seeking Health is a low sodium and high potassium. I mean, that's really moderate potassium. And when I recommend the 500 milligrams of potassium, I do recommend getting a couple potassiums in, a month or two, and just kind of peeking in on the potassium and making sure it's not going up.
Okay. And just take it throughout the day, or can I do it all at once? Or could she do it all?
Can do it all at once.
Thank you.
A person could do it all at once. Yeah, Pam?
Hello.
Oh, hi. Oh, there's two Pams.
Oh,
There's Pamela, we're almost at you. Pam.
Hi, yeah, I'm here. Yeah, okay, I just got
Hi,
unmuted.
Pam.
Thank you so much. This is so fascinating and helpful. A couple of questions for this person that I know. One is she's in her 70s, and her gynecologist said he could give her HRT. She's got osteoporosis, and starting with like a 0.25 patch and 100 milligrams of progesterone. And her scores for her osteoporosis are left hip minus 3.3 from a minus 2.9 2 years ago, and femoral neck minus 3.5 from minus 2.5 2 years ago. Lumbar spine is minus 2.7 from minus 2.5 2 years ago. And so she's just wondering what would be your thoughts about doing HRT?
Well, so I can give you so like I said before, when my patients go on HRT, I don't see a lot of big improvements in the hip. I'm not saying I don't see big improvements on the DEXA scan in the hip. I do believe that the hip is getting stronger, and that it's just not showing up in the DEXA. The lumbar spine does respond, and I see anywhere between like a 3 to 7% per year. Like I said, that my patient went from negative 3.7 to negative, I can't quite remember. I think it was negative 3.7 to negative 2.8. So almost the standard deviation in the lumbar spine over 4 years. So lumbar spine can improve pretty dramatically, but the hip DEXA stabilizes. And if the hip is at a negative 3 something, then if I had a patient whose hip was negative 3.5 and wanted to go on HRT, I would tell them I'm not going to potentially really see a big difference in the hip on HRT on a DEXA. Doesn't mean it's not going to be stronger. Exercise could definitely help, but maybe that's a medication case.
Okay, yeah. And also she was prescribed Fosamax, and which she obviously worries about. And she's just wondering, some doctors say switch to Timlos, but you've been mentioning that you like Evenity. Is there a reason that you like Evenity over Timlos?
Yeah. So I don't ever recommend Fosamax. I don't think I recommend Fosamax for anything. Dr. McCormick will give Fosamax as a rebound for Evenity and Timlos sometimes, but I prefer IV reclass. I don't like Fosamax. I don't like the bisphosphonates. I really don't. I think their only role is to be a rebound medication because they do not build quality, and the studies show that. And in fact, they worsen the quality over the course of 3 to 5 years. They worsen quality potentially. And so I don't like them. I don't prescribe them except for the extreme situation where I talked about the anastrozole and those kinds of situations where a CTX is just crazy and I need a bit of time to like kind of buy that person a little bit of time, then I might recommend IV reclass. And then the other situation that I recommend bisphosphonates is for rebound. So I'm just saying that as a general thing for just people to know that if people are getting recommended Fosamax, and if you're on it, you know, but you didn't know, but I think they're outdated drugs and they have their role and a very specific role. So Timlos and Forteo are parathyroid analogs. There are anabolics, and they do a pretty good job of increasing bone density. Evenity is better. Evenity is stronger. Evenity has a black box warning on it for cardiovascular risk. So what I do for Evenity, and I saw that there was a question in the chat. What I do for Evenity is I look at a person's LP little a, lipoprotein A, and I check to see whether it's high or not. And less than 90 is normal. Like if somebody's 120 or 140 or 150, I might be really, really careful of them with Evenity. And whether they have a coronary artery calcium score that's above 0, really kind of above 100, above 150. Somebody with a coronary artery calcium score above 150, LP little a above 100. I'd be really, really careful about Evenity. They can't have any like current chest pain or, you know, symptoms. They really have to be evaluated by a cardiologist, but that's what I do in addition to what the cardiologist would recommend. But Evenity can provide almost a full standard deviation at the lumbar spine and anywhere like about a half of a standard deviation at the hip. And it's only 1 year, and then it has to be followed by all the anabolics have to be followed by a bisphosphonate.
That's time, Dr. Millman.
All right.
Thank you. That's super helpful. Thank you.
Okay. All right. Bobby. I have sun coming in my eyes and all over the place over here. All right,
Isn't it time to get up and close your shades?
Yes, it is,
I was wondering about that.
How nice. It's so dark here in the East Coast. There's no sun right now.
Dark and cold, although it's better than it's been.
It's actually hot in here. I can't even believe it. It's February. It's hot in here. Okay. All right. Let's go, Bobby. Oh, and Kristen said she can't raise her hand, so we should talk to Kristen too.
I think we got Kristen in, didn't we? Or no? Oh, okay.
Okay, Bobby.
Unmute, Bobby.
You're still muted.
Sorry about that.
That's okay.
All right. So with long-term osteoporosis, severe, I was taken off Forteo because a unrelated hand X-ray showed calcium deposits on fingers. Wondering if you think that's a good reason to be taken off it, but also, so then, because I had already been on it a year, the doctor has me on Fosamax, which I don't like, have avoided.
All right, Pamela, way too much detail. You're definitely asking for medical advice.
Bobby, okay, wait.
Can't do
let
it.
me change
Can't,
then.
sorry,
Okay,
sorry.
let me
Yeah,
change it.
Bobby.
So,
take a piece of it and ask a
okay,
general
that's what I'm gonna
question
do.
about it.
With Evenity, how long do you take it? Do you have to go off and on it? And yeah.
Okay.
Is there
Evenity,
rebound? Yeah.
all the anabolics have rebound.
Okay.
So Forteo, Timlos, and Evenity all have rebound. They're all anabolics. Forteo or Prolia has rebound. the bisphosphonates have no rebound. Evenity is a 1-year drug. It is I think it's phenomenal. I think it's a phenomenal drug. It does have a rebound. It's a mild rebound. And so probably my patients are on Evenity for a year, IV reclassed for a year and a half, 2 years, they're done. They've gotten a standard deviation in the hip or in the spine, a little bit in the hip, and usually that's it for them. But if somebody is like starting at a -4 or something like that, or the hips are really bad. So in the instance where the hips are really bad, so let's say that they do the year of Evenity and their hips are still at -3.5, that's one of the only reasons that I will ever give Prolia. And then Prolia, because Prolia does a really good job at the hip, can get the hip down a little bit more. And then you have to do IV reclass because the rebound from Prolia is so bad. You have to do IV reclass. And then you have somebody like me who's watching you for the rebound of Prolia. You have somebody like Dr. McCormick who's watching you for the rebound of Prolia, and you get the rebound done correctly. And in R&R, I have a whole module on medications that teaches you how to do a Prolia rebound.
Yeah, I think I'm gonna have to take the course. But so with if you've been on Fosamax for some time, that makes the Evenity less effective. Is that true?
It does, but there are still ways to do an anabolic. The CTX has to come back up. So the CTX has to come back up to like 350, 400, and then it's okay. Like, so that can take like 6 to 9 months, something like that. It's not going to actually take that long for the CTX to come up, but I still think it's a good idea to wait 6 to 9 months before you would do an anabolic. But it can be done.
That's 3 minutes.
All right, Pamela?
Hello.
Hi.
My question is a little bit different. I am looking for my root cause. Like, how did I get in this situation with osteoporosis? I was having this conversation with my 3 sisters who are all older than me. They're in their 80s. I'm in my 70s, and I have the worst T-score.
Yeah.
So we're looking at root causes, and the only thing comparing our lifestyles that we could see is that I have been drinking reverse osmosis water for the last 35 years.
Well, so you know that reverse osmosis water doesn't have any minerals in it, so that could leach some minerals, and if you're not replacing the minerals, then that could be a definite issue. But in so Restore and Rebuild, my class, is a 14-week class that has root causes on every module, right? So,
and I am enrolled in your next one.
So that's fabulous. So I couldn't possibly start to go into all of it. But there's lab testing for all the root causes. There are symptom assessments. So, I mean, for stress, for example, there's a stress assessment and a cortisol assessment, and then you can do the Dutch for as a cortisol. But you can kind of like walk through the lab assessments, the symptom assessments, and then you kind of see, oh, maybe this was something I hadn't thought about, but this is potentially one of my roots. And it could also be that it was a root earlier in your life that's kind of resolved now. So it's not just looking at what's happening now, but what also happened from the last couple of decades. So I'll just say that because it's just way too big of a topic.
Okay, thank you.
But you'll learn it.
Yeah, okay. And I do want to give a big thank you to both you and Margie for just working so much with the osteoporosis community. Thank you.
Thank you for that. Okay, so we have should we do Kristen? Because Kristen, yeah, we better, well, let's do Kristen now. She has some, so go ahead, Kristen. You're probably gonna, because so Kristen has been in R&R several times. She is an extremely good student, and she's going to ask a couple of questions that are a little bit advanced. So if you don't, so go ahead, Kristen.
How do you know I'm going to ask advanced questions?
Because you put it in the chat.
Oh, okay. I thought those were the easy ones.
Those are advanced questions.
Oh, or do you still use the GI map for your
I do.
Your stool tests? Okay.
I do.
And then the what was the other one? The Dutch test has a new format now. I didn't know. Have you done a video with the new one? The new format?
You know, I've done a video with the practitioners, but not for R&R yet. But I can tell you really quickly about it. So there's two sliders, right? And so the 20H is the green one, remember? The 40H is the red one, and the 16OH is the blue one. So we always want more 2. So we want the ratio from 2 to 4 to be closer to 2, right? We want the ratio from 2 to 16 to be closer to 2. We always want the ratio to be closer to 2 because that's the protective one. On the slider, it shows you one side's the 2, one side's the 4. On the other slider, one side's the 2, one side's the 16. They have an optimal zone that goes from 20% to 80%. If you're in that optimal zone, they think that's okay, but I would rather say, see, 50 to 80% would be better than 20 to 80% because that's a big range.
Is that their green zone?
And you that's their green zone, right? And you always want that 50 to 80% to be towards the 2 because that's the good one, right? That's the only way that you that's it. That's the way to read that slider. I like the pie chart, but you know.
Yeah, that's all right. Just a quick about heart health. If a person had like an optimal NMR panel and low oxidized LDL, good LP little a, pretty much all those basic tests, but still has a little bit, maybe a mid-20s calcium scan score, is trying to figure out what might be causing that, and if any of those other tests are necessary yet at this point, kind of those more advanced tests.
I mean, I'm not really that concerned about a 20 coronary calcium score. It's, the cardiologists are kind of saying, well, that's mild to moderate.
Yeah.
Yeah, they say, I think their moderate is at 100 or even 200. So that's mild. Now, if I had a patient who had symptoms like chest pain or palpitations or something like that, I would send them to a cardiologist because, as you know, the coronary artery calcium scan is looking at hard plaque, not soft plaque, and the soft plaque is what's vulnerable. So then I might send one of my patients to a CT angiogram and get this clearly analysis, which shows the soft plaque. And then if there's hardly any soft plaque, I'm not really worried quite at all. And some of the later Cleveland labs that maybe you haven't done, which is like the myeloperoxidase and the LPPLA2, that's like, if that stuff's positive, that's bad. Right? So you can kind of, may give a person more peace of mind to have those later, because that's when like plaque is really forming and it's like the blood vessel is inflamed and part of that is part of the earlier stuff is HSCRP, and you remember that whole artery wall,
Yeah.
right? The whole artery wall in the Cleveland labs.
It's
Right.
time.
Everybody see what a good student she is. I told you. I told you all.
Thank you.
Yeah. You're welcome, Kristen. Good to see you. So Susan L, not Susan Leibowitz, but Susan L.
Yes. Can you hear me?
Yes.
Okay, because I can't see myself on the screen. I don't know where it went. But anyway, thank you for your time. Couple quick questions. Regarding collagen peptides, I have been purchasing a brand that touts theirs is the best because it has Fortibone,
Yeah.
which is a special blend. Apparently has some clinical data behind it. Do you feel that that's necessary? Because it is pricey. I'm looking at another high quality, 100% grass-fed GMP manufacturer. Do you think the Fortibone is worth it?
Oh, that's a hard question. My preference is perfect amino over the collagen anyway. And so if somebody's going to spend money on protein, I'd rather see them do that. But it's not going to be exactly like the collagen. So some people like to mix the perfect amino and the collagen. And there's I don't know that the Fortibone is all that important. What do you think, Margie? This is Margie knows this too.
I think that I like to use things that have research behind them. So if I'm going to use collagen and they've done studies showing improvement in bone density and other things with the Fortibone, so I always choose, I like the Designs for Health. What is it? Every body I'm trying to think.
Yeah, it's
It has
whole body
whole body
collagen.
collagen. Yeah. So I personally take that and I take the perfect aminos. But I think that's just my feeling that, you might as well use something that has been shown clinical evidence. So that's
Right.
yeah.
Okay. And then what are your thoughts on REMS versus DEXA, Dr. Millman?
Yeah, so DEXA's gold standard.
Right.
I would never tell one of my patients not to get a DEXA. Like I'm always like, when's your next DEXA? When's your next DEXA? We're always looking at when they're going to get their next DEXA. If they want to get a REMS, they can. I consider it auxiliary additional data.
Yeah.
And when the REMS do not agree with the DEXA, I'm going to favor the DEXA because it's the gold standard, right? And so I'm never going to make a diagnosis off of a REMS. I'm always going to make the diagnosis off of a DEXA. So do I have patients going to get REMS? Absolutely. Lots of them do. Lots of them do. And we actually have one of the best REMS experts in the country coming up to Marin from North Carolina, which is Andy Bush. And so I'm specifically recommending that my patients go see Andy Bush because he's excellent at doing the consultations and very experienced. And so it's really important to get an experienced
Yes.
technical person, technologist, and consultant. So I think that if anybody's close to Marin, I would absolutely recommend for them to go to Andy Bush and see him.
That's 3 minutes.
Oh, shoot.
Sorry about that. Maria? Maria B.
I'm here. Sorry.
Okay.
Oops. Oh, okay. First, I actually, you mostly answered my question, but I wanted to tell you how much I really appreciate you being here. And I've sent a lot of people, both to you and to Margie. I work with a lot of women who've had breast cancer, so different group, but still to look at, the kinds of things you're doing. I have a particular issue, I'm still a little concerned about this K1 issue. Only
Okay.
some of the people actually have either pre-existing coagulation issues. It might be on Eliquis. I know it's not an issue in terms of it's
Okay,
not.
hold on. Let me just like jump to it. So none of the studies have been done with people with coagulation issues like factor V Leiden or protein S or protein C deficiencies. None of those studies have been done in those people. We do not know what will happen to those people. So in those people, I just say, maybe a little tiny bit of MK7. I don't even know. So
Yeah.
so I am not recommending K1, K2, and K2 in those people.
Yeah.
I am not, those are not the people. But in people who do not have, and Eliquis is not a vitamin K
No,
antagonist,
it's not.
right?
Right.
What do we think about a bunch of K1? We think theoretically it's going to increase the clotting factors because in a person without clotting disorders, right? We think that a lot of K1 is going to increase clotting factors, just clotting just because the factors are there. No, because our body is so intricate, right? It's got all these guardrails and to stop this kind of thing from happening. If you've got a bunch of K1 and you don't have all the other coagulation factors to speed that process down, you're not going to have increased coagulation. I don't believe that happens. And maybe I've read 200 studies. I mean, I'm really serious that I've read 200 studies about vitamin K. And I have never seen increased strokes, increased DVTs in like up to 10 milligrams K1, which is a huge amount.
Yeah.
And 15 milligrams 3 times a day of MK4 and of up to 720 micrograms of MK7. No, I have not seen one study where they say that there's increased risk of heart attacks, strokes, or DVTs.
Right. Yeah, and we are cutting out the studies done in Japan that were found to be that they were faking data. So, I mean, that's a big issue.
No, they already redacted that they said yes, there were a couple studies that I don't even know what the problem was, but they updated the whole analysis and it was still incredible data.
That's time.
I know that people will say, "Oh, well, we're not Japanese women over here."
Now
It doesn't apply to us.
No.
So I don't agree with that.
Yeah, me either. Yeah, I just worry about super physiological doses of anything, and that's why I just want to make sure about the K1 in that product. I'm kind of looking at Thorne K2 drops as being the best choice for somebody where you want to go really low just because you don't want to take any chances.
If it sounds like you're a practitioner and if that's what you want for your recommendation to be, I can tell you that in 15 years, I have been recommending 15 milligrams of MK4 twice a day, and I have never had a DVT or a stroke in any of my patients, and I have 4 or 5 patients out of 800, 600, somewhere around probably 800 patients who have fractured.
That's great. Okay, thanks.
So tell me that I'm doing something wrong.
You are. No, you're not. No, I just wanted to confirm because it's hard for me to find all the studies.
But I understand your reluctance, and I would never tell that in a person with a clotting disorder.
Yeah, a lot of them are on these drugs because they have arrhythmia. So it's not really a clotting disorder, it's concern. It's that kind of
right. But in a clotting disorder, like factor V Leiden, protein S, protein C, I probably wouldn't give them any recommendation.
Okay, thanks.
You're welcome. Jane?
Hi, I'm
Hi.
here.
Oh,
I just have a
wrong
quick
Jean.
question. Oh,
Sorry.
it's Jane.
Jane.
Sorry. Oh,
Oh, I don't
Jean.
know.
Oh,
Jane.
Jane, sorry.
okay, I have quick questions. So I think you answered it about the osteoben. If a
Yeah.
person's on HRT, then there's no need to take genistein, or
Well,
can it help?
what I'm saying is that it would be low priority for me. So if a person is trying to cut costs, then I'd probably say you don't need the genistein. But there are some practitioners who like to mix estradiol and estriol. And estriol is and that's called Biest, and that's a weaker estrogen than estradiol. And it may be that it buffers estradiol a little bit. And genistein, it acts just like estriol does, although it's much weaker than estriol. So could it be buffering estradiol? Maybe. So, that I don't see really a big downside in taking genistein if isn't a cost issue for people, but it's a low priority if people are looking at cost.
Okay, thank you. I just had one other quick, and so I'm trying to get more protein,
Yeah.
and I'm looking at different protein powders, and I'm very confused.
Yeah.
So if a person's lactose intolerant, can they do a whey-based protein powder?
So typically, lactose intolerance is a misnomer. So most of the time, if somebody is dairy sensitive, they're sensitive to the proteins, which is whey and casein.
Oh, okay.
So I would say if dairy bothers a person, they should not do whey protein powders.
Then pea protein is okay. I mean,
Pea
there's
protein would be okay, but perfect amino is my favorite.
so I'm confused with perfect aminos that, so I have that, but I don't know how is it equivalent to protein powder? How much?
Yeah. Okay, so do I remember this data? Oh, I might have to have Kathy Beck help me here. So or maybe Margie knows this. I think that it's 5 grams per scoop, which is equivalent to 3 times what you would get in foods. So that's 1 scoop is 15 grams. Am I right, Margie?
No, I always have to look back on their website to exactly what
I
it
know,
is.
I forget. Kathy
Yeah.
Beck, you probably know because she's such a smarty. Because I saw her in the chat. Kathy, is it 15 grams? Marty knows. See, these are all my students. These are all my smart little
It's right
students.
on the website, though. And it's for different things as well. Like when I spoke to him, that it's certain proteins are more absorbed than in others. So it's interesting. He correlates it to different things.
Yeah, so I'm in
It's
Keith's
different
group.
depending on what it's being compared to different proteins.
Okay. Okay.
Right, I know, but in general, isn't it considered to be around
Okay.
right, but I think it's considered to be yeah, but none of that makes any sense to me, Kristen. I think what I heard was that it's considered to be around 5 grams, but really kind of like 15 grams of. I know what they're doing. So what they're doing is they're saying that um
Yeah, that's exactly what Kristen wrote, was exactly what he said.
is
Yeah.
that it has to do with the efficiency at which the amino acids turn into protein in the body, and so it has to do with how the food converts into protein in the body. And so eggs convert different than meat does. Poultry converts different than whey and soy, etc. But what my sales rep said that in general, it's about 3 times the 5 grams, which is 15 grams.
That's time.
Okay, thank you very much.
Yeah, see, we used to talk about perfect amino for hours. Okay, Linda.
Unmute.
Yeah, right, Kristen. I think
I'm so
that's what I
thankful
said too.
to both you and Margie for, I've followed you for years, and it's just awesome to hear people who are really evidence-based and, researching it from that perspective. So thank you. I'm in your class coming up this next,
Awesome.
so that's great. I have a question about exercising with weights for somebody who has a negative 3.6 index in their spine and negative 3.0 in their hips. Is there anything they have to worry about in terms of like, is that okay to do with weights, or is there's no narrow class in the vicinity, but.
Want
That's
me
a
to
Margie
answer that?
question.
Yeah. So that question, you should really work with a physical therapist. It doesn't have to be an Onero practitioner. You can go on BoneFit two ways to do it. Go on BoneFit, and you can see practitioners in your area. If you go just like Google BoneFit, or I think I made one tinyurl.com/PT BoneFit. But you can go on and find that, or just go to choosept.com and put in either geriatrics or put in women's health. But I wouldn't do it myself, because it's really important to see your posture, to see how you're stabilizing. Like there's so many factors that go into it. Just because of the bone density would not preclude you from doing weights and doing stabilization, and so yes, I would just work with someone.
In a class, like an osteo fitness class with 30 people, is that okay?
No, I would not do that. I would go one-on-one
Okay.
and to see, because if your bone density is that, let them see what's going on, because you want to make sure your posture is good. You don't want to put any extra force in areas that you don't want it. So I would at least go a few sessions, just to get the evaluation, and they can tell you, how you're moving, that it's safe and it's not putting too much force in areas that we don't want it to be.
And then the second quick question for Kim is, I have followed the recommendation for the Claire MK4, and then followed the change in the recommendation for MK4 plus MK7. So the Thorn capsules are what's recommended now, just twice a day?
Yes, exactly. So it's Thorn vitamin K, has 1 milligram of K1 and 5 milligrams of MK4 and 90 micrograms of MK7. So because of the half-life of MK4 is just I can't remember, 3 hours. It needs to be taken twice a day, and so because of that, I'm recommending that twice a day.
Okay, great. Thanks so much. See you
You're
soon.
welcome. See you soon. Susan Leibowitz.
Well, hello.
Hello.
I am so glad to be here.
So
Can
glad
you
to
see
hear
me?
you're here. Good to
I
see
can't
you.
believe, I think it's going to be 2 years since I took the course and then became your patient. So
yes,
I'm hoping to get into the alumni thing. I think I might have missed.
No, you didn't miss it.
Okay. Okay. Well,
So the first content drops on March 7th, and the first Q&A is on March 12th. So we're going to register all the way up until March 12th.
Oh, perfect. Okay.
Just find your email that says the alumni. I'll make a note of it to send out another alumni email for everybody that, kind of last chance.
Okay, wonderful. Yeah, because especially as I sit here today, I'm like, yeah, I need a refresher on everything. It's been a while. Even though I've been your patient, I still can do it. Yeah. So as I've sat here and heard other people's questions and answers, I'm finding myself a little even more confused of my question, but it has to do with the markers, the CTX and P1NP. I'm finding it confusing. So
I'm going to quiz you.
Okay.
What's the optimal range of CTX?
I think is it 250 to 350?
You're an excellent student.
But is that
and then what about the
PG or NG?
What?
What?
Is that measurement in the PG/ml, or is it an NG/ml? I think that's where I'm getting myself confused.
If you go to LabCorp or Quest, whatever that unit is, I mean, I can look it up right now pretty quickly, but whatever that unit is, it's 250 to 350.
Okay.
It don't, if you want to go to Europe or Australia, you may have to do some conversions.
Okay. So is a number, like, I'm just wondering if it's possible that someone's numbers can be too low. So if you saw a patient or saw someone who has
a CTX of
under
100?
Yeah, a CTX of 85.
Yeah.
And a P1NP of 20.
Yeah.
What does that say about,
yeah,
is there turnover happening? Like, is that too sluggish? Like,
it might be.
If they're exercising, are they going to be getting the benefits?
Yeah, it's a little bit low. Yeah, it is a little bit low. Under 100, I start to think about a low turnover osteoporosis where so when I think about low turnover, I think about low metabolism in general. And so there are a lot of different reasons for that. So the big ones would be low thyroid, low iron, um, just low nutrients, low protein, low B12, low folate.
My gosh.
All kinds of nutrients that are in that metabolic pathway, mostly thyroid and iron. Thyroid and iron will really do that.
Okay.
And then a sluggish liver and insulin resistance and blood sugar problems. And so those are low metabolic states. And so all those need to be evaluated.
Okay. And
Sorry, that's time.
Oh, shoot. Okay. Thinking about hair loss. Okay. Thank you.
Well, hair loss is related to a lot of that stuff, especially
The
iron,
ferritin.
iron and protein.
Okay. Thank you.
You're welcome.
Okay, Dr. Millman, it's 8:02. I'm not sure.
Okay, so why don't we talk about our two programs? And if you want, like, I can stay till 5:30 and answer some more questions if you could keep the line open and you could
Okay, I
leave.
can stay. No, that's okay. I'll stay.
I don't want you to have to stay.
Okay, so you want to share? You have it
Yeah.
on your
Yeah. So we've been talking about my program all night, which is Restore and Rebuild 100 Days to Healthier Bones. We call it R&R. And as you've seen, we've got many, many students who are here and who are continuing to learn and continuing to do this work. And when you think about it, this is kind of a long process. And when you think about our bones are affected by all of our metabolism and all of these processes in the body. And so what we're really trying to do in R&R is to systematically go through the root causes and how we evaluate doing lab tests and doing symptom assessments for, do you potentially have one of these root causes that is feeding the fire, right? And so this is the process that must be done, is to look at the root causes and to mitigate all that. And Margie and I both say that when you do this, it makes you healthier overall, and it's actually could be considered to be an opportunity. And then we're discussing medications and the red flags and exercise and stress and sleep. And so this is what R&R is all about, because I can only see people in California. There aren't a lot of medical doctors who have this kind of expertise, and usually it's not in all of osteoporosis. Maybe they may have a expertise in HRT or something like that, but they don't look at all of this. So this is my way of providing a framework for anybody to be able to follow. And then we've got weekly Q&As, except for every 4 weeks we take a break because we want to have some time to rest, recuperate, catch up. And people love the Q&As. They're just like they are here. And so if you felt like this Q&A has been helpful to you and you really want to dig into your own situation, R&R is a perfect place to be. And so we're enrolling people right now. So the first content, we have content that drops on Saturdays. First content drops March 7th. We have Q&As on Thursdays. They're at this time, 3 o'clock Pacific every Thursday. Again, integration weeks, every 4 weeks we take a break. It goes 14 weeks. And there's all kinds of bonus materials. I think there might be 5 or 6 modules that are bonus. When you enroll, you automatically get access to your portal and you get to start on your bonus stuff. And then we walk through the other 14 modules. No, there are 10 modules. The other 10 modules are dripped once a week, except for on integration weeks. And we're registering until March 12th to give people a little bit of extra time. And that is the first Q&A on that first Thursday. And we pre-submit questions. Those questions are due at 9 a.m. in the morning, but we don't have the actual QA until 3. So we're ending registration at 3 p.m. on that first Q&A day. We'd love for you guys to be there. Our special price, usually it's $11.97. The special price is $7.97. And for Margie's community, we have a $100 off coupon if you use her coupon. And it is Happy S26100. And the place for you to go is the Millman Clinic R&R. And is spelled A-N-D. So R-A-N-D-R. And so we'd love to have you guys come. There are tons of my students who are here who, if you wanted to ask somebody, we would love to have you. Joanne, hi, Joanne. So yeah, we like, and like, we just love to be together too. So that's like, you just.
Some of us have taken it a couple of times.
We have 46 people who are taking it again.
Yeah. So there you go. It was, it was a great to start and a great refresher, and it continues to be great.
Yeah, and this all doesn't happen overnight, right? This is like a work in progress. And things change. And so we all kind of get together and do R&R again.
Right.
And I teach 2 of the classes too, so that's fun. I get to be part of it as well. And
Yeah,
then let's talk about the second program. Do you guys want a QR code? I can put the slide up again if that would help. Does that help anybody?
Maybe Melanie can drop the QR code into the chat. Can she do that?
Do that, Melanie?
I actually don't have access to that. Sorry.
Oh, you don't have access to the QR code?
Okay. All right, I'll put it up on the
Margie, all you need to do is drop the PNG into the chat.
Oh, okay. I'll do that. Okay, well, we keep talking. Do you want to talk about our other program? The other program, this was my idea was R&R. I didn't call it that, but I said you have to do a program, and you exceeded yourself and how good that is. But anyway, then Dr. Millman.
And then what I said was, Margie, what's happening is that we get all these calls in clinic and I have to send people away because I can only see people in California. And, yes, I send people all day long to Dr. McCormick, but, maybe he's pretty busy too. So then we thought that it would be a great idea is to start to train practitioners. So that's what we're doing. And so both Margie and I co-founded the Bone Health Academy. And if you're a practitioner And this is the kind of community that you want to work in, which, I would highly recommend it because it's very rewarding. There's an incredible demand. People are really grateful, and the community is lovely. And so I think that it's a wonderful specialization to have, and that's what we do is we certify integrative bone health practitioners in this framework. And so if you want to learn more about that, it's over at thebonehealthacademy.com. And we are starting May 11th is our first date. We have a cohort. We can only take 30 people at a time. We already have 6 people who have applied and have been accepted. So we have 24 more slots. And so if you're interested, you go to thebonehealthacademy.com and you can learn more, and then you can apply.
Yeah.
And
it's
you
been
have
so
to have some background. We can't teach you all the way from the ground up. So you have to have some background in functional medicine.
Yes, I can't seem to get it off the slide. So
Okay. Oh, okay. All right. So yeah, so Lori.
Okay, so I guess you can hear me. I've had a hard time with my screen going off and on and doing some strange things. So I guess I've got some good news to share. But I have a question at the end of it.
Okay.
So I just had my DEXA yesterday, and over a period of 26 months, I went from minus 4.4 down to minus 3.5 for my lumbar T-score. So that was a 17%.
Holy
Now,
moly.
I did have 4 months of Avinity in there, so it wasn't
all.
But here's the thing: the first, from the time I started bio HRT with the patch, I gained 8.67% in that very last month prior to that DEXA. I had just started Avinity. So I understand that Avinity doesn't calcify, in the DEXA, so that it wouldn't have showed up. But so I'm pretty stoked because I originally did the scores not quite right. So I recorrected, did the math properly.
Really good.
So, and my hip, I
Yeah.
actually gained in my femoral neck, 7.6%.
Yeah.
Which
Wow.
I was pretty excited about. However, I'm still at minus 3.5 in my lumbar, minus 3 in my femoral neck. So I met with my endo and trying to decide what to do next. She says, you really do still need to be on some type of a med to try to get better, your bones better. I did have a fracture. Years ago, kneecap fracture, weird wipeout. So my Avinity journey was challenging. 4 months, which is, well, I only got 4 months. Significant amount of pain, fatigue, stupefying fatigue, and muscle weakness, muscle, hand cramping, and just very easy fatigability, sleeping for an hour to 2 hours to get through a day. I know that Avinity is lots and lots of accolades and whatnot. Is there situations where it may not be good to re-engage with it? Or the endocrinologist said, it's been a year, maybe try it again, but we're kind of looking at Forteo. So I'm kind of at a loss. Maybe I should just even continue with the bio HRT. So I know that's almost asking a little bit more, but
it's a lot of detail. It's a lot of it's okay.
So I guess my question
let
more general.
Let me just try to give some general knowledge that might be helpful.
Sorry, just how to deal with the Evenity
So one of the things that I know about, when I look at the patients that I've had on Evenity, most of the time they have no side effects whatsoever. And a few times patients have had some side effects on Evenity. Forteo and Timlos are almost universally more side effects. So I'll have patients that are dizzy, who have headaches, who have fatigue, incredible fatigue on Forteo and Timlos, and that hardly ever happens on Evenity. But what can happen on Evenity is that Evenity, and I didn't really realize this until a patient like kind of showed it to me. This patient's like a good student, and yeah, I know. Most people have no side effects on Evenity. Um, it does chew through your calcium and your vitamin D. So you can go low in your calcium and you can go low in your vitamin D. And if a practitioner monitors that and accounts for it, then maybe that is why some people have um, more side effects on Evenity, especially a person who is having a really good response might be chewing through the calcium and the vitamin D. If you think about it, like you're building bone, it needs more calcium, is going to grab it from the blood, right? So people become hypocalcemic. So that is one way to think about it. And so if I had a patient who had that kind of, first of all, Evenity has a rebound, and I would never let my patient go without anything for a year. I wouldn't let them stop Evenity and at least take some Fosamax for a rebound medication for one thing, but don't tell us what happened with you. Um, and and so, but if a patient had that kind of response on Evenity, I would try to figure out why, and I would put them back on Evenity and measure their calcium and vitamin D, and if it was going low, then I would have them really bulk up on calcium and vitamin D and have them try to get through a whole year of Evenity is what I would do. That's what I would do as a practitioner.
Okay. Yeah, my calcium did go a little bit low. But then it rebounded, popped back up. So I, yeah, I would like to have had better monitoring on that, but doctors don't always order stuff the way it'd be nice to.
All right. Well, we're because I kind of got into that realm of
okay. Well,
being too close to medical advice, we're gonna like go ahead on to Barbara. And
I'm monitoring now, Melanie.
okay, and Vasan is asking you to answer that in her chat maybe, but okay.
Yeah.
Nice to see you, Lori. Barbara,
Hi, can you hear me? Yeah, I have a quick question about if somebody's on Timlos, started on Timlos, has never had a fracture but has a very severe spine, and has been on HRT but a very low dose since starting early menopause in the early 40s and now is in the she's in her late 60s. Okay, what started Timlos, okay, and if the Timlos does a good job, but still doesn't bring the spine below -3.5, is it okay to then start Evenity right away? Can you do that, or do you need to do a little rebound? And then
okay, so
what do you
there's
think?
okay, hold on. So I think I have this in my notes and I have it in my class, but I have to look it up. So there's one way to go. One is really good and the other one is not good at all. I mean, as far as Forteo to Evenity or Evenity to Forteo.
No, it would be Timlos. Timlos.
Yeah,
Yeah, I
Forteo,
get the same
Forteo
thing.
Timlos doesn't matter. Same,
Okay.
same mechanism. So hold on just a minute. Oh, it's probably right here. It's Timlos to Evenity could be very good.
Awesome. Okay. Also,
You know, because we're so late and we got so many people, because you did ask one question, let's just,
okay.
I'm sorry to like
Thank
cut
you.
you
I
off, but
appreciate
I'd
it.
like
Thank
to
you for
just
being
do
here.
one question per person now.
Got it. Thank you for answering. Thanks.
You're welcome. Allison.
Thank you so much, Dr. Millman. And this is a corollary question to Barbara's to make sure that I understood something I heard for the first time, a bridge concept. So someone in their 70s did not have the advantage of hormone replacement therapy, did her best in every regard to try to keep the bone strong, but now is in a point of needing the meds under 3.5, both spine and femur. How does this bridge concept work? It's an integration, I understand, of HRT with whatever med
No,
is
I'm not saying
appropriate, or how does?
No, let me go through this concept like just again with you. Okay, so the first part of it is short term. So that's a very good thing for people to understand, because the traditional doctors are really telling their patients that they need to be on, the concept is once you start medications, you're on them for life. So there are integrative doctors who, like myself, Margie, Keith McCormick, we believe in short-term medications. We believe that no matter what, you need to do natural all the way through, because you need to understand your root causes and you need to figure out why everything happened to begin with, because otherwise you have to be on meds for the rest of your life, because whatever has happened before is probably likely to still keep happening. So you build your bones up, but you're constantly you're constantly degrading your bones because you haven't worked on the root causes. So it's a bridge, right? The short-term medication is a bridge from natural to natural. Right? It doesn't, but bridge probably sounds as though you stop the natural in between the meds, which is not actually the case. It's that you work on root cause like you do like R&R. And you get into that whole flow of things where you're working on root cause, working on root cause. You do a short-term medication, and that kind of bridges you. That helps you to build your bones up. You do, my short-term bridges are only anabolics with a rebound, and but it's you do it for a short term. Now, if somebody starts a -4 and they only get to -3.5, then they do all the root cause stuff and they only get to and they're still at -3.5. Now, do they maybe have to do like 3 years later another round of Evenity? Maybe. I can't. That is a very unusual situation.
And cannot be attributed when a doctor says genetic, your mother, your sister, you're this. We're talking epigenetics versus genetic. Yeah.
Well, I would say that when I say that there are these big needle movers, those big needle movers on the other end of them are the big root causes, right? So lack of protein, lack of exercise, lack of estrogen, right? And then parathyroid problems. Those are the big, huge needle movers. So, with those things just will destroy your bones really quickly. And do they have much of they don't have genetic reasons for them, you know.
And to understand, parathyroid means not the levothyroxine
No,
was
that's
mentioned.
thyroid. Parathyroid
Thyroid is
is basically when you have a little tumor in your parathyroid gland and it's causing parathyroid to be really high, or you have low calcium or low vitamin D and the parathyroid starts to hyperfunction because you've got secondary hyperparathyroidism because of the low calcium and the low vitamin D that, you know, your doctor thinks your doctor, so the end of the calcium range is 8.8, but 8.8, you're going to get secondary hyperparathyroid at that.
Yep.
9.0, your doctor thinks 9.0 is fine. It's not. 9.2 is the point at which you have to be above in order for the parathyroid gland not to kick in. So,
No.
and
But it
you know,
sounds,
yeah. So
sounds like you're still okay with the short-term meds and a little bit of HRT in conjunction.
I think it's a fantastic combination.
Okay, 3 minutes. It's already 8:25. Do we want to
All right. All right. Let me try to hit a couple more. So Linda,
Didn't we get Linda before?
does anybody have any questions about R&R where they need to know something before they can join?
Jean does. Oh, Jean and Barbara do. Okay.
Maybe we should take them because, you know, we want to get people into the program because that's going to help people more than us spending 5 minutes on a couple small questions. I do these Q&As all the time too, by the way, you guys. She has me on all the time.
Are you doing another one this year or only in March?
Yes, so there will be one in usually I think we start it in August. We'll have fall. We'll have a
Okay,
fall
okay.
one. Yeah.
Also, I live in California. Are you accepting any new patient? I live in Southern California.
So Lauren says no, but call Lauren and put her and tell her that you were in this Q&A.
Okay, all right, great. Thank you, and thank you for doing this.
We're into June right now.
Yeah.
For new patients. Anybody else have the R&R questions?
Jean does.
Jean?
Hi. Just a fast question. Are there any concerns with someone who has AGTS?
What? With what?
Hypermobile Ehlers-Danlos? As
Oh,
far as,
gosh.
I mean, will there be any things I would need, you know what I mean? Modifications or whatever?
Yeah, Bobby, we're doing that now. We need to have people take the course in order to be a patient. Um, uh, well, I mean, I can tell you that Evenity is contraindicated for Ehlers-Danlos, but as far as being an R&R,
Now, the HDES is the one that has no genetic, they haven't found the genetic link yet, but they know it is familially related. So I don't know if that's a different, it's a
not a
different.
contraindication for taking R&R course.
Okay,
You
good.
can take the R&R course but it does make things a little more complicated for the situation.
Okay.
Any
All
other
right.
like real quick R&R? Yeah, we'll record. We'll keep the chat, right, Margie?
Yeah, we can give you the chat. Sure. Thea, can you see
Thea.
Thea.
Hi, we were late. I guess we got our time all mixed up. If we watch the replay, will it explain what the program is, or like?
Let me just. Should I put the slide up? Yeah.
I mean, I can do it really, really quick.
You wanna put
Okay,
the
so
slide up?
we start March 7th.
Right.
The price is $7.97.
Right.
Margie has $100 coupon off.
Yeah.
Her coupon is happy S26 100. And Margie, let's put the coupon here. Happy S26 100.
Putting the slide up.
That's $100 off.
You
And
see it?
it's so we have once a week content drops, but every 4 weeks we take a break. We take an integration week. And it's 14 weeks long, 10 weeks of content, and then you've got like 5 or 6 bonus modules. when you come in, you start to like if you enroll now, you would basically just start working on the bonus modules. And then there's a lab testing guide that tells you how to get the lab testing done on your own or how to ask for it with from your doctors. You start getting your labs all together. And then as we go through, I show you the labs that we're going to go over, the symptom assessments that have to do with that root cause, how to interpret it, and if there's problems with those, what is my natural protocol for mitigating those root causes. So it's just like being a patient of mine, except for you don't get the hand holding and I don't actually tell you what to do. I mean, you have to interpret the labs yourself, but there are Q&As where you come in and you ask me questions. And the Q&As
Not
are
as
just
many
like
people,
this.
we have hundreds of people tonight on this call. So it's
Yeah.
not as many people, so it's
Yeah.
not, it's much easier to get your question answered. And as you progress, I think that's the beautiful thing about it. What people seem to, what everybody always tells me is thank you so much. And the thing is, as you progress, you can ask the question that pertains to you at that point. So that's
Yeah, no, that's right. And I have a kind of I really try to get all the questions answered. So I typically will go late. So it's not no.
And what about we're in Canada?
Yeah,
The tests and everything are fine?
We have plenty of people from Canada. I can't say that it's easy to get the labs done. And I and we have a couple of supplement companies like iHerb. It does ship to Canada, and
Right.
you can buy the supplements. And if if the supplement that I recommend in the protocol isn't available, I try to help you find something on iHerb that you can do instead.
Okay, thanks very much.
And you can just use if you're interested, you can just use your phone and use the QR code too, and it will come up with all the information.
Yeah,
Thank you.
it's at the Millman Clinic /R and R.
.com, Millman Clinic.
Oh yeah, the millmanclinic.com. Yes.
It's on the slide here. Yeah. You
Yes.
can just use either one.
Yeah.
Thank you.
Okay. And then again, the practitioner, just if anybody's practitioners or practitioners, you just go to the bonehealthacademy.com and let them know, because it is, we're only taking 30 people and everybody gets tremendous attention, and it's been so great. So we'd love to have you if you're a practitioner.
Yeah, and we really haven't we haven't done any pure talks to practitioners yet. It's only been like some of the podcasts that we've been on and talking to a mixed group. So then once we start talking to practitioner only, it's gonna start filling up. But even without talking to straight practitioners, we already have 6 people signed up. So we only have 24 slots. And that's without doing really
any outreach to practitioners.
Yeah, any outreach to practitioners at all. So it does fill up. It does fill up. It will fill up. And we have an MD, we have a couple nurse practitioners, and so that's another thing is that once these practitioner certification, once they get certified and graduate, then that's just going to open up other people for us to refer any and other people too. So it's going to be really good. It's going to be an intense ripple effect, which is what we're after.
So I think I'm sorry to end it. Do you agree, Dr. Millman?
Yes.
I'm sorry. You can, if there's, if you have a pressing question, you can always send it to my support team. You can write to support@margiebissinger.com and we can see what we can do. But anyway, all right. So the way we end these things is we'll say, thank you so much, Dr. Millman. You always bring such brilliance and knowledge to everything. And I know you've helped so many people thumbs up if you've gotten something from today's. Yeah, lots of thumbs up. So we always think of a word to end. Anyone have a good word? Dr. Millman, you want to pick a word for ending? Or
boy, I would say let's see.
we can just go strong bones too. We can.
Well, I was gonna say 13% improvement in DEXA score. That's not one word.
It's not one word. We're saying strong bones. Okay.
Strong bones isn't one word either.
No, but that's two words. We can say strong bones. Okay. All right. So thank you.
How about stronger bones?
Stronger bones. Okay, that sounds great. So everyone, you'll get the replay tomorrow. That's the plan. And yeah, and if this is something you liked, join R&R. I think you'll love it. And again, practitioners, we would love to have you, or if you know practitioners, let them know about it. Because we can't do it ourselves, Dr. Millman and I. We want this to get out to everybody so that this becomes how people look at osteoporosis. All of you are so impressive because you've sought this out. So I give you so much credit, and you're doing so many great things. It always amazes me. And just from listening to the questions, you guys are on this, which is so good. And I think only good things will happen. So thank you. So on the count of three, we'll just say, thank you, Dr. Millman. Bye. Stronger bones. Ready?
Thank you for the stronger bones.
Thank you, Dr.
Thank you, Dr.
bones,
Millman.
everyone.
Stronger
Stronger
bones.
bones.
Thank you. Stronger bones.
Bye, everybody. Let me save.
Good to be here.
Everybody.
Thank you.
Okay.
Oh, Pam has 8 pages of notes. Yeah. She's a good student.
You can save the chat here too if you go to meeting chat, but I will save it.
Thank you, Deborah.
Okay, bye. 8 pages of notes. That's so funny.
You want to join in?
Bye, everybody.
Bye, everybody. Bye-bye.
Bye.
Bye.
Everybody on the replay and YouTube. Bye.
Bye from